All right, so I'm here with Avi, Mike the Vegan, Danielle Belardo, and we're going to, well, I'm going to moderate. These three are going to have a discussion about whether a vegan diet reverses cardiovascular disease. You know, we're all going to be friendly here, despite differing opinions. And I take moderating like this. Okay, no one comes to a debate to watch a moderator, so ideally, I'm going to talk as little as possible. I'm only going to speak up if there's a technical problem, if it really needs moderation, or if one of the parties requests moderation. So if you guys can leave me not having to speak at all during this whole encounter, that would be the best. And I would just suggest, since there's going to be viewers from each of your communities who aren't aware of each other, I would say that you guys should all just start by introducing yourself, relevant credentials or whatever, and then just crack into a discussion as you see fit.
Sure. I'm Avi. I'm a vegan medical doctor. I guess I'm a YouTuber now as a hobby. Yeah, that's basically it.
All right, I guess I'll go. I'm Mike the Vegan. I have a YouTube channel. I'm studying a master's in public health, mostly done, not a doctor, so it's two doctors versus me, so we'll see how this goes. And yeah, that's about it.
I'm Danielle Belardo. I am a cardiologist. I'm board certified in internal medicine. I'm currently studying for my cardiology boards. I'm COCATS level 1 in cath. I'd like to specify that, and also boarding in cardiac CT.
All right. Okay, so the proposition we came to discuss was, does a vegan diet reverse cardiovascular disease?
And also, I think,
now,
sorry, not to interrupt, I don't mean to jump in, but
yeah,
like,
sure.
Whenever we say vegan diet reverses cardiovascular disease, everyone listening has to understand that it's like such a painful terminology that people use, because cardiovascular disease can be defined in so many ways. It could be coronary artery disease. Are we talking about systolic heart failure? Are we talking about valvular disease? Like, you know, it's like we have to really like specify if we're talking about specifically. I guess this talk is going to be specifically about coronary artery disease.
Okay, I would just wonder then, so if you're seeing any reversal in any cardiovascular disease, wouldn't that be a potential to reverse some cardiovascular disease?
Oh, do we have data that shows that any cardiovascular disease like systolic
We're going to talk about it.
Can be reversed with diet? Because
what do you think? Okay, what do you think a threshold? Okay, let's just talk about for a second. I just want to clarify this. So yes, there's many types of cardiovascular disease. The question though is, if somebody goes in and has clogged arteries, has various disease symptoms, if they have they have cardiovascular disease, if they are then able to get rid of those symptoms, do you consider that a reversal of heart disease?
You have to say that. So that's not just cardiovascular disease. You're talking about coronary artery disease, right? So like, I'm sorry, that's just butcherizing my specialty. So it's got to be, we have to specify, because if I was talking to an electrophysiologist, we would say, like, you have to understand, within my specialty, there are people who specialize in each of these things. To you, that you were just using an umbrella term for cardiovascular disease, there are literally people who do extra years of training for each one of these, right? So systolic heart failure is different than coronary artery disease, which is different than peripheral arterial disease, which is different than atrial fibrillation, which is, you know, so here.
Well, for simplicity, let's do coronary artery disease.
So
although there are going to be some
disease, I imagine, just because that's the trial.
Yeah, well, there are going to be some principles that are just artery related in general that I might mention, and so I hope if it's not particularly in the heart, that is still considered relevant to what happens in arteries. It's not considered relevant to like an artery mechanism. What can happen to an artery wall is not relevant if it's in the heart versus the rest of the body. Okay.
Well, I'm gonna just pipe in because I kind of know where this is going, and we can talk about like retinopathy and stuff like that, and like we can talk about like rice diets and whatnot, and why that would be different, and why also we should be very skeptical about that data. But like right now, we should stick to the CBD reversal.
Sure, I actually wasn't planning. Yeah. Okay, yeah. Let's go into it. CAD reversal then it is for now.
CBD. Yeah. And specifically, we're talking about plaque, and the reason. So there's different ways of defining it. I completely agree. There's different cardiovascular disease is an umbrella term for very different things. There's systolic heart failure, diastolic heart failure. There's coronary artery disease. There's atherosclerotic cardiovascular. What I am what I'm trying to look for is a bar that is set for other interventions, which there
Right.
is. That is a standard that is used in the medical literature, in the cardiac literature, to judge interventions of whether they reverse CVD. Regress is the word they use, to a clinically relevant degree. And there's a very
we're talking
specific
about plaque
criteria.
regression then.
Yeah.
Do you want to talk? Okay, we'll start on plaque regression.
Okay. So there's a specific criteria that's used to judge other interventions for whether there is or is not a clinically relevant regression of plaque. And for that, you need to have two things. So number one, you need to have a change in a nominal change in 10% absolute stenosis or greater. And number two, you need to have a minimal luminal diameter increase of 0.2 millimeters or greater. That's the standard which rosuvastatin was judged against, and when they were looking to see if it would clinically relevantly reverse disease. So whether AstraZeneca, the pharmaceutical company AstraZeneca, can advertise their statin as something that would reverse cardiovascular disease. I'll just tell you right now, it doesn't on average. Sorry, Danielle, you wanted to say something?
Oh, I just wanted to jump in and say I fully agree, and that's consistent with data, statin data.
Okay, I would like to see the link on that because there are
Sure.
some studies I'm going to mention that are in the realm. They're like approaching that on the edge. Some are slightly over. Obviously, they're not. They're actually talking about statins. So I want to talk actually about statins. So I have the main question here is, do you believe, I guess it's to both of you, do you believe that plaque regression is biochemically possible?
Yes,
I do not know.
Well,
it could be possible.
Biochemically possible. It's biochemically possible. Sure. The question is, do we have any interventions that are non-mechanical, obviously,
Agreed,
that do regress plaque to a clinically relevant degree? I mean, we obviously have mechanical interventions that regress plaque.
Yeah.
You can rotor-rooter it out.
Okay.
You can stent it.
We can literally, we can stent anything and make it from 70. Is there any intervention besides a stent where you can we take a lesion and and Mike, I've done like hundreds of caths, and you can literally take a lesion and you can stent it and make it go from a 70% to a 0%. So do we have any more medical or dietary intervention that can do a similar thing? Absolutely not.
So my question is, okay, so moving on, my question is, do you believe that there is any ability of the human body to clear LDL out of the wall?
Probably to some degree, sure.
So you're granting that you can regress plaque then?
Well, no, not to correct. When we say regress, wait. When we say regress plaque, again, we're talking about to a clinically relevant degree. It's a very strict criteria of what that's defined to be. When we're not going to talk about like, oh, well, we're going to reverse cardiovascular disease, but it's going to be 0.00 whatever percent stenosis.
Correct.
Obviously, that's not the numbers in the studies, but that someone would be very facetious if they tried to do that and say, oh, so technically that's true. No, we're talking about what a clinically relevant degree is. What is the standard that's published in the literature that's considered the bar that needs to be met for them to be able to make that claim?
Okay, so but you do agree that the artery wall is capable of healing. Like, for example, when you are injecting somebody with a needle and you take it out, you agree that their artery wall can heal.
Yes.
Okay.
So we cannot base this study on hypotheticals, though. I mean, this entire discussion on hypotheticals. It's just
I'm just laying the groundwork for a biochemical mechanism.
Because we're not. This is not going to be discussion on mechanisms. This is going to be a discussion on data and not mechanisms. This has to be an actual.
All right.
I'm going to present both, so I still need
Mike, to answer your question. So to answer your question, Mike. So yes, I agree. An artery can heal itself after a needle poke. The question on the table is, do we have any interventions that are shown to regress plaque to a clinically relevant degree as defined by the criteria that's in the literature that other interventions are tested against? That's the question on the table, and my answer to that is no.
Okay, I want to get to that. I want to circle back to that in a second, but basically your position, okay, so the wider position here, let's just, for people who are watching who probably don't know what's going on, I have claimed that cardiovascular disease can be reversed. Obviously, we're talking about coronary artery disease right here, and I base that off of various things, including Esselstyn and Ornish's study. You guys will, basically, you guys fully reject any meaning to anything that happened in Esselson's study. I just want to get that.
No.
Is that your
No,
position?
no, no. I don't
Incorrect.
reject
Incorrect.
anything meaningful.
Okay.
No.
Good to know. That's
So-
good clarification.
So there's several meaningful things from Ornish and Esselstyn's study. So
Agreed.
for Ornish, the meaningful thing in the Ornish study is that the plaque did not progress in the
And-
experimental group.
And this is what I consistently try to emphasize, that I think what Dean did in his study, regardless of study design, whether that, first of all, wasn't a vegan diet, also that smoking cessation was only in the experimental group, etc. But regardless of study design, things like that, the fact that there was no progression of plaque, I thought was incredibly important and is very high utility in discussing lifestyle modification with patients. But it's the disease regression in which of what clinical significance that 3% is what me and Avi are talking about here. And then I agree with Avi too with the Esselstyn studies, similar thing. I mean, study without even discussing or bringing up study design, of course it's clinically meaningful. Me and Avi both agree that you can reduce cardiac events on a plant predominant diet, that lifestyle changes are wildly important. We just don't stand behind the claim that, which is just not proven, that you can clinically significantly reverse coronary arterial disease with a dietary or statin intervention.
So if you put somebody on a plant-based diet, predominantly entirely plant-based diet like Ornish is, or a vegan diet, and you see an improvement in coronary artery disease symptoms, do you not consider that reversal of disease, or do you just consider that stopping of disease?
No.
So even though you're having a go for it.
Yeah, no, it's not. You don't consider that a reversal of disease as defined by the criteria. So there's many different things that can reduce symptoms and reduce events that don't involve clinically significant regression of the plaque. In fact,
I mean, listen, half of our medications we give are called anti-anginals. Okay, so when we put someone on guideline-directed medical therapy, they all reduce symptoms. That includes beta blockers, that includes nitrates, that includes calcium channel blockers. These are all medications we put on patients which make them symptom-free from anginal chest pain.
Okay, so my question is,
that does not reverse their coronary artery disease. That just makes them symptom-free.
So here's a distinction I want to ask about then, because if you have symptoms that are then being suppressed or masked or stopped based off medication, that is the medication. But if you have changes within somebody's body that then stops that on their own, their body is reversing that disease to the point that they have no symptoms. And so I think it's a matter of semantics of what reversal is.
And it's not semantics. Disease reversal, there is no semantics about what disease reversal is. Like Avi said, it's defined in the literature. There is no semantics about what disease reversal is. You are putting someone's symptoms into remission. You're improving their stable angina, and that is incredibly important. Whether I'm, I think that vegans are losing the forest for the trees for this entirely important topic of the fact that plant-based diets, plant-predominant diets are so important. They can help with anginal symptoms, all of these things. That's so important. But that does not change the fact that if someone has a 50% or greater left main lesion, okay, just because your symptoms improve, you still need a coronary artery bypass surgery. If you have a 60%, if you have a 20% LAD, if you have a 10% LAD lesion, it doesn't matter if you go on a plant-based diet. If you have established coronary artery disease, you need to be on a statin. So these are the reason why the coronary artery disease reversal it's not actually reversal. Symptom improvement we see with multiple anti-anginal medications. So yes, it's incredibly important to do it with lifestyle and diet. It's also great to
the key here, the key here is you can actually see symptom improvement with disease progression, not just regression. You can progress the disease. The disease can get worse and symptoms can improve.
Okay, but what if somebody goes from having symptoms? What if somebody has a single symptom from heart disease, and then they reverse that symptom, and then they no longer have manifestations of their disease? So you're saying they still have their disease.
You're talking about reversal. Yeah, then you're talking about reversal of the symptom, not reversal of the disease.
Not reversal of the disease. We're talking about. So you have to understand that what we look at as physicians, what we're looking at is this going to change my patient's prognosis, and is this going to change their clinical outcome of what I'm going to do with regards to is the clinical management going to change for the patient? If someone has a 50% left main in their coronary artery. It does not matter what diet in the world they are on, they're going to need a coronary artery bypass surgery. This is just well established in the literature and in the data, in the ischemia trial, for example. And, it just depends on the lesion. And if you're like, just because someone's symptoms goes away doesn't mean that we suddenly don't do bypass on certain patients. Or, for example,
I agree. I would just want to say right now that I'm not for people going plant-based to dodge any conventional medical care. I think they should both be done together. But I
exactly.
still.
So that's why it's not called disease reversal, because if I took a catheter in that patient, so I mean, listen, we just don't have, I'm not going to give hypotheticals, but I'm just trying to make you kind of understand like what we're talking about with regards to the disease process. We just don't have data that shows that 5 years later, what we saw with Ornish's trial, yes, there was, a 3% disease regression, which Avi can give you again the statistics, which from the statin.
By the way, I don't even accept the 3%. We'll get into why that's even spurious.
And I totally agree with you. But the fact is that, so even Mike, even if you're talking about someone that does fantastic on a plant-based diet, their symptoms go away. If we put a catheter in them or we put them through a coronary CTA and they still have a 70% LAD lesion just because they're symptom-free, it does not mean their disease is reversed. Because I can
even though I'm not talking about curing, I'm talking about backtracking. You're saying there's no, if somebody's life, if you tell them they've had all of this coronary artery disease symptoms, and they have a timeline of going more and more symptoms, and then they change their diet and they get rid of all those symptoms in their life, their disease is being reversed for all intents and purposes.
You've reversed their symptoms. You have not necessarily reversed the underlying disease. In fact, the underlying disease could have actually progressed.
Absolutely.
Which is listen. This is not an uncommon thing. Your disease can progress and the symptoms can reverse
all the time. And we see this with systolic heart failure all the time. I can't tell you how many times someone can go from NYHA class 3 to NYHA class 1 and their EF can still be 25%. Symptoms are an important part of our patient's clinical scenario, but that does not mean structurally what is underneath has changed.
Okay, so somebody who couldn't maybe walk up some steps and can again, their disease is not reversed. They should not believe that they had any disease reversal. So I just want to
100%.
Okay.
Same thing with heart failure.
Yep.
Same thing. You'd have to be seen with imaging. I cannot tell you how many times patients with heart failure, we put them on guideline directed medical therapy and they go from what's called NYHA class 3, which is a functional class of symptoms, to NYHA class 1 with the correct medications or diuretics, especially if you think of the Starling's curve. Okay, for heart failure is a perfect example. Someone could be volume overloaded. They can't walk up a flight of stairs. You're giving them Lasix. This is not prolonging their mortality. This is not doing anything for them, but you've reduced their preload. Suddenly they can breathe. They can go from NYHA class 3 to NYHA class 2, and they can suddenly walk up a flight of stairs. That is not disease reversal. Furosemide is not even actually prolonging their life, but it's actually just reducing their symptoms. So while it's incredibly important to help reduce patients' symptoms, and there are plenty of benefits of plant-based diets beyond just symptom reversal, but that's not disease reversal. It's just improving symptoms.
Okay, I'm really curious to know what you guys think about the angiograms then, because we briefly discussed it, but we never actually have spoken in real life. So you guys have the position that any of these angiograms that are taken through any plant-based diet are not actually showing any reversal of plaque. They're just, there's something else going on. Is that correct?
Well, no, not necessarily. It could very well be that some of those angiograms are disease reversal. But the issue is then if what we need is a methodological way of determining if the intervention has reversed the disease, or if we're just cherry picking the best performance in an intervention. And you can do that for just about every intervention.
I'm confused about how you say that it's impossible to be reversing the disease or narrowing arteries.
Wait, I never said that.
Sorry. You're saying that it's not correct to say it, but then you're saying that, yes, in fact, maybe that person did get a reversal. I mean, you understand how there's a bit of hypocrisy there.
I can clear it up. So there's a distinction between saying that we cannot say this individual patient had his CVD reversed, and saying this individual patient had his CVD reversed in virtue of a plant-based diet. The question is, what methodology do we have to determine if the CVD reversal, even if we can have a few cases, was due to the plant-based diet or just due to some statistical phenomenon which there's going to be some outliers. So that's where we need certain...
Okay, from a logical perspective, this is... Yeah, okay, finish your sentence.
Yeah. So that's where we need things like statistical significance. There are ways of doing this. We have certain your averages, you have means. Even if you want to have certain thresholds where you say, okay, well, even if we take the top 5 performers and compare it to the top 5 performers of like another group, we can see if anyone meets that bar or what percentage meets that bar, and if it's statistically significant, that's fine. What's not okay and what's not going to meet that bar is any sort of cherry picking of caths when we can't without an image, whether it's rotated or not, or whether it's the same angle, even if it is, and just say, okay, look at this. How do you explain that? That doesn't do it.
And
okay,
Mike,
but I'm trying.
Mike,
Yeah, go
you
ahead.
can even see the difference. You can even see major variability in one cath within one case. I was explaining this to Avi even within a 5-hour case, you can see a lesion look entirely different based on someone's hemodynamics. If they have aortic stenosis, if they've been given cardine, if they are hypotensive, if they become hypertensive. I mean, even within a case, there's so much. So that is why there would need to be, and I'm not saying it's not humanly possible. And we are actually at our practice at IOPDM, we're going to study this with cardiac CTA. But first of all, cath is not even the gold standard.
So you are interested in asking the question still?
No, we're actually just, what we're interested in is the fact that I think that what's more important, that we're really losing like the importance of the value here, the fact that disease does not progress. I think that that's incredibly important. But to say disease reversal, first of all, when you're looking at a cath, you're not even looking at soft plaque, okay? You're just looking at what's calcified. When we look at soft plaque, if you're looking at using IVUS, OCT, or cardiac CTA, okay? So that's an intravascular ultrasound.
Yeah, and I want to talk about those in a second.
Right. So there's been no studies about that with nutrition, okay? So there's so much variability within cath that, like Avi said, in order for any of these studies to have been actually effective, it would have to be great trial design and allow for different statistical variability and things like that.
But I want to just ask, okay, I'm going to back up, and I don't want to get too into anecdotal principles here, but just in terms of what is true of the human body, just for a second, backing away from what we can claim based off medical thresholds or whatever, medically accepted thresholds. I mean, imagine that you have, and this is a crazy analogy, but imagine you have somebody who takes a potion and they literally fly off the ground. And we have recordings of those people flying off the ground to then say that that does not allow that person to fly. You understand what I'm saying? If we can see it, I mean, at least this is a point to what Avi is saying, that yes, it's possible. But if somebody can literally, like the potion literally allowed somebody to fly, you see somebody flying, it might not happen to every person who takes that potion, but to say that that is not ever what's happening.
Oh, no. I reject. I don't think showing a cath like that is something that would naturally just be impossible and would not be and we can go into other pictures of angiograms that look very amazing, and I have to look into I don't have them on hand right now, but I reject the idea that it's like pigs flying or something like in one of
I'm saying
other
that
debates.
I was just saying that to emphasize the point that if it has actually been documented, then saying that it hasn't been documented is not valid as well as...
Well, no. Here's what we're saying that hasn't been what's not been documented is any methodological evidence, any methodology showing that in virtue of a given intervention that there has been reversal of cardiovascular disease to a clinically relevant degree. That's what has never been documented.
Okay, I want to move on. I want to move on to angiograms because this is what everybody everybody who's vegan and plant-based and interested in this, they see those angiograms, they go, yes, that is reversal. And so my question is, from what you told me a while back, was that, of course, these angiograms are only showing blood flow. Therefore, you do not know what is going on in the artery, and they can be, like you're saying, they can be manipulated. My question is, isn't it the job of the angiographer who is maybe taking images and SLs and studies to go, okay, when we see something that looks like stenosis, now we need to do some type of test to figure out if it is or not, whether that is, from my understanding, propofol or some type of artery dilation that would then show. No?
So I'm gonna let Danielle get to this question, but I just want to really hammer the point home, Mike, because the objection is really like, we can quibble over the angiograms and whether they're the same angle or not.
Like,
we can quibble over the
guy in here, and he can just, oh god, yeah.
Right. Well, but this is all quibbling. This is all like, and we can do that. We can quibble through the angiograms and whether it's a vasoconstriction or whether it's not, or whether it's as realistic in 3 weeks to increase perfusion, or whether it's a different angle. Yes, that's all beside. That's all in the
Beside
forest.
the
Like
point.
the big
Right.
picture, yeah, it's all beside the point. The big point here is that this is not how you establish that an intervention actually
Correct.
leads to that outcome. You
Correct.
don't establish an intervention leads to an outcome by taking the best responders and cherry picking them and showing it on some PowerPoint slide. What you do
Correct.
is you have some means, you see if there's a statistically significant difference, and if it's clinically significant as defined in the literature by meeting that bar. That's how you do it. Or if you want to do it, you can take the tails of the population and you can say, okay, and say what percent of the population of the tails met that bar. That's what they did with Crestor. You can do those things, but that's never been done with these interventions.
So you, just to be clear, you reject that there was any evidence of reversal in Esselstyn's study or Ornish's study, and we'll talk about Ornish's study in a second.
I reject that there was any evidence that there was reversal in virtue of the intervention.
Correct. And
You
you
see the
cannot
distinction?
and I'm sorry, you cannot
Okay,
make the decision of disease reversal based on just one shot of one angle of one catheter. That is just not how.
So Mike, real quick, you have to appreciate the distinction between saying there's a difference between saying there was disease reversal in this patient and or in this study, and saying the patients in that study who had the disease reversal were in virtue. There's evidence that it was in virtue of the intervention.
So you're saying they could have accidentally, even though heart disease reversal spontaneous. Do you think spontaneous heart disease reversal is possible and likely, or?
I have seen impressive angio. I actually have seen. It's funny you mentioned this because, and I wish I actually did save this for this discussion, but I actually have seen the same quote unquote cherry picked impressive angiograms in other contexts. Now I think they were on certain medications, statin medications, but
I've actually also seen some people. There's been certain individual circumstances of a few people in the carnivore crowd who also claim individual cases where actually they have cardiac CTA where they showed individual people have shown improvement in cardiac CTA. And so listen, are we going to start to say that also the carnivore diet, can also reverse CAD based on one or two individuals who claim this? You'd really need an actual robust study. I'm not saying that it's not possible that some soft plaque can improve, or that there can be an improvement. There may quite possibly be, but we've never seen that to date with regards to an actual.
Okay, I was under the impression that you guys were locked down on this door is closed. It does not appear possible mechanistically or anything like that.
Anything's possible. We don't know.
That's possible, Mike. It just hasn't been shown.
That's a distinction. I'm happy to hear that from you guys.
It's possible. Even the carnivore. I'm not even joking. And obviously, everyone conversation is not a carnivore. Like, I haven't eaten meat in a gazillion years, but even the carnivore diet people have claimed disease reversal through cardiac CTA. So, but guess what? I will not be starting my patients on the carnivore diet based on one anecdotal case.
But you don't think that these things can. But you don't think that these things can kind of compound together? We have, for example, like I mentioned in my last video. I don't know what you guys' thoughts are on it, but of the statistical difference in adverse events between the Esselstyn study and just a standard background rate of people over about a decade, like combining seeing the angiograms with seeing these things.
So I have to jump into this. Reason why I just want to jump in this. So I want to just state for the record, there is a reason why I am vegan. I'm literally the director of cardiology in a practice called the Institute of Plant-Based Medicine. Like, I believe in plant-based nutrition above and beyond, especially in cardiovascular. I'm on the ACC nutrition committee. We have a very plant predominant guidelines for cardiovascular disease. I totally believe in the data that shows that a plant predominant, healthful plant-based diet can help reduce cardiovascular risk, cardiovascular mortality. I believe in all of these things, in addition to guideline-directed medical and procedural therapy, 100%. And I think that there's so much value in multiple different studies, ranging on various levels of evidence, from epidemiology all the way down to even case series like Dr. Esselstyn's. I think it's very important to show that a plant-predominant, plant-based diets can help reduce further cardiovascular risk. But that is very different than saying coronary artery disease can be reversed.
Okay, but what I was trying to say, and I appreciate all your work, you're doing great work. thing that what I'm trying to say is that yes, you have this particular criteria that needs to be met in a randomized controlled trial under these particular conditions, but when you have a greater picture of what might be happening within the body, is that not a case for a potential disease reversal just because it doesn't reach one particular metric in one particular sphere of that you're saying 10% stenosis reduction?
No, we're Mike. I don't know why we would think that there's clinically relevant disease reversal. Now, I just want to get back to what you said before. When you talked about the Esselstyn study, I can quibble over the statistics, but I agree with your conclusion anyway. Yes, you're talking about events. You were talking about statistically meaningful differences in events. And I agree. Going on a plant-based diet, I agree. That's meaningful evidence from the Esselstyn study. You were statistically significantly have a meaningful difference in your outcomes. Great, that's awesome.
Great.
I agree with
Fantastic.
that to begin with. That's
okay. So
we don't.
Yeah, my next question. If you're ready.
Yeah, go ahead, Matt. Yeah, sure.
My next question then is, what would you say to, maybe you've talked to him, maybe you've like changed his mind, but what would you say to someone like Dr. Kim Williams, former president of the American College of Cardiology, 2015, 2016? He has several plaque regression slides in his presentation that show the Ornish trial. They show other studies talking about how plaque regression is possible, and he mentions the Esselstyn study. So what would you say? Like, so instead of just like, there's a crazy YouTuber out there saying this, there's also a major, what I consider to be a relatively accomplished cardiologist saying this. And he's saying that he got onto he was voted president partially due to his work in the field in imaging. So clearly he understands it. So why is it that he's making this claim when there's not enough evidence? So what would you say to him?
So,
or
Mike,
do you just agree with him? Do you think he's wrong?
If the specific claim is plaque regression is possible, we already agree with that claim. Like, we already, no one's saying it's not possible.
Exactly.
So if Kim Williams goes up and says that plaque regression is possible, we agree. If he says it's, and he points to the Esselstyn study or the Ornish study to substantiate the claim that plaque regression is possible, that's fine. What we would take issue with is if he claimed that in virtue of a plant-based diet, clinically relevant cardiovascular disease regression will happen.
I'm pretty sure the presentation is literally called the Prevention and Reversal.
Okay, well then, you know what? Then I'm happy to talk to Kim.
I just don't want to seem like I'm like, obviously
So
I'm presenting opinions.
I don't think anyone should speak for Kim.
Yeah, that's fine.
I know Kim personally, and he's brilliant, and I know for a fact Kim would never be advocating that that coronary artery disease can be so reversed to the point where it is clinically changing management. We're taking patients off of statins. Literally, Kim wrote the primary prevention guidelines, meaning he believes in guideline-directed medical and procedural therapy. Therefore, I've never seen Kim advocate for plant-based diet, reversing heart disease with regards to coronary artery disease to the point where people don't need procedures or interventions. He believes in the combination of guideline-directed medical therapy and procedural therapy. And so I will not for him, but I mean, he has literally written the guidelines, which very much outline that, and he is brilliant. And so I think that's the only way I can imagine that he would continue to advocate for.
So you're saying, and we can clear it up, and like I hopefully didn't misrepresent any of his views, but so you're saying that anybody who has a clinical manifestation of or diagnosed with heart disease, whether through angiogram or whatever, should be on statins for the rest of their life?
Oh, okay. So this is inarguable, and this is literally in the guidelines, the American College of Cardiology guidelines that Kim wrote, because he is on the guidelines committee. He is brilliant. Kim is one of my very good friends and mentors. So we're talking about primary prevention, secondary prevention are two entirely different things, okay? So primary prevention is when someone doesn't have known CAD. Now, that doesn't mean that they don't have CAD. It just means we don't know they have CAD. So if someone is hyperlipidemia and they have a risk score that puts them in a category using multiple different things, that puts them in a category where they need a statin. If they don't have cardiac disease, if they don't have heart disease yet, it actually gives us a chance to say, yes, sometimes I will say to my patients, the guidelines allow me sometimes to say, okay, I will give you a few months of diet and lifestyle change if they have no coronary artery disease, okay? And then if they do not make a change in their lipids, then we have to put them on a statin. But if we're talking about secondary prevention, which is defined as anyone with any known coronary artery disease, and this is now we are using is even a coronary artery calcium score anything greater than 100, even we're giving aspirin. Even if you have a coronary artery calcium score of 5, if you have any known plaque on your coronary artery disease, that is now considered secondary prevention. And those are people who should be on a statin lifelong, no matter what, because it's not just about lowering your LDL, it's about plaque stabilization. And there's pleiotropic effects of statin that are important in heart disease. Okay, so that's where when people think they can reverse, where the misnomer, which is dangerous, so I've had 2 patients thought they could reverse their coronary artery disease based on diet. Both decided to not undergo guideline-directed procedural therapy. Both had massive heart attacks, and one had to have a transplant. Okay, so avoiding guideline-directed medical and procedural therapy in lieu of a diet because you think it can reverse your heart disease is not safe. And that is what me and Avi are adamantly fighting against with regards.
Yeah, and I think if the message should be modified at all, like if at the end of this I walk away still thinking that a vegan diet can reverse cardiovascular disease, I will be trying to emphasize the point that you should also be continuing conventional treatment because
because we don't have data that shows us that a vegan diet can reverse plaque to the point where it's 0 and you no longer qualify for secondary prevention.
Not even 0. Not even 0. It's way less than that. Like we don't even have to hit like.
So you do believe that in theory over 50% of the U.S. should be on statins based off, at least from my understanding of studies on donated hearts that were allegedly healthy. 53% of them had I believe they classified them as severe coronary lesions.
I have no idea what
that's not necessarily it's not necessarily the case because there could be factors that increase the risk that lead you to know about the cardiovascular disease in someone who may not have had it otherwise, which accounts for part of that risk. It doesn't necessarily follow that if you were somehow omniscient, then those people should be on statins.
Okay, so I want to move on to just a couple things that I found that I think are interesting, and I really want to hear you guys' responses.
I'll try to ask you a question though, Mike. Can I just ask you something? With respect to the definition of clinically relevant cardiovascular disease reversal, clinically relevant regression of plaque, do you have any evidence that a plant-based diet causes that level of progression of plaque as defined in the literature of what clinically relevant regression is?
I believe, based off what I want to talk about next, that I just want to say likely. I still think we need more. I think that, okay, I'm going to say this right now, and this is going to say, oh, you're ridiculous, and you're, I don't want to say like worthless, but the idea that match, like I'm just going to say right now that I reject that as being the only metric of reversal of heart disease. And so I want to talk about I want to talk about some studies. You can respond to that and just say, yeah, you're.
Okay, so can I just stop you there? Because if you're going to say you're going to use vascular ultrasound as a way to say someone's reversed heart disease, that is not an effective way to say you've reversed heart disease, because vascular ultrasound is a hemodynamic measurement. Okay, so I'm taking my vascular boards also. So listen, I'm not trying to be condescending here. I just understand that for me, it's taken 10 years of training to understand these various imaging techniques. Okay, and they each have their own board exam, so it's very nuanced. But you're going to say that a vascular, so an ultrasound test, yes, endothelial function is important for various reasons, but you can't say based on a vascular ultrasound that's disease reversal unless someone has coronary artery disease and you've looked at a cardiac CTA or a cath and you've seen that the plaque is just gone. Do you know what I'm saying? So vascular.
Wait. You're saying the plaque has to be gone for it to be regressed, for it to be reversed?
No, but you can't. We don't have a study that shows it's regressed even with cath.
No. I just want to pipe in because I don't believe my question's been answered. So, and I'm sorry to bring it back to this, but. So I get that you want to have a proprietary definition of what regression is. You reject the standard that's in the literature, but that still doesn't answer my question.
Because that is particularly for asking a question about what does a drug therapy do, and I think that this is different because it's full system change.
That's fine. I don't think then you'd have to then we're going to go into a name the trait game, and that's fine. But regardless, I want the question answered first. So the question on the table is, with respect to the standard. That other interventions, such as statins have been put against. With respect to that standard of clinically relevant regression, do you have evidence that a plant-based diet regresses heart disease? Yes or no?
I have evidence, and I would say in terms of just
can you
an inference, but I would say that it has yet to be, and I have no problem saying this, it has yet to be established that a plant-based diet intervention meets those standards. I have no problem saying that.
Okay,
It could happen in the future, but just because it doesn't, I just reject that that is what you need in order to say
So
that
the
there's
answer-
reversal going on
Okay,
based
that's
off
fine. We can get to
a
that.
larger principle of what's going on in the human body. And so let me
That's fine.
just
We can get
ask, let's see what you
Is
think.
the answer
Okay.
no? Wait, hold on, Mike. Wait, hold on. So is the answer that you don't have evidence, you just reject the standard, or is the answer that you reject the standard, but you also have evidence that a plant-based diet does meet those criteria? I just want to be
I
clear.
reject the evidence. I reject that standard, and I have evidence that it may in certain cases be able to, and we can talk about that, and you can decide what you think about it, because it's a bunch of IVUS studies, and so I just want to know, because that's, I believe Danielle said that's the, if we were to do a study,
I'm
like
looking-
we should be
Oh,
using
IVUS.
IVUS.
Oh, yeah. I thought you were going to just mention regular vascular ultrasound. We have an IVUS study that shows plaque regression with a randomized control trial. I've never heard of it.
Okay. You've never, of in general, you've never heard of a IVUS study showing plaque regression under any?
No,
yeah,
a
with
randomized.
diet.
No. An
Randomized.
interventional study, Mike. She's talking about an interventional study with
Plant-based
IVUS
study.
showing like there was a
Plant-based,
statistic.
plant-based. I'm saying what I'm going to present to you, and maybe it's not up to your standards, but I'm going to present to you that the results that were found in statin studies are approximately what can be expected. Maybe I'm wrong, and you can say that's not true, based off the LDL levels that we see in vegans, that we had an IVUS study literally saying, quote,
But no, but you're talking about statins. You're not saying with a plant-based diet. You're just
I'm saying that the
doesn't answer the
results
question.
that they measured in terms of the exact LDL reduction and the LDL from baseline and the average LDL in that study was equivalent to the average LDL of
So Mike,
people.
do you think that statins reverse coronary artery disease?
I'm going to talk about that. Can I talk about that right now, just for a sec? Can I just present what I found, because I'm really curious to see what your response to it is.
Sure.
Okay, so 2019 study. Gonna find it right now. Okay, 2019 review talking about randomized control trials on using IVUS and measuring plaque regression, plaque atheroma volume, etc. And they found here I have, you're saying it's not enough because not all of them reach that. Some of them do reach that metric, but not all of them reach this 10%. Although the 10% regression you were talking about, was that stenosis?
It's a conjunction. It's a conjunction, Mike. So you need two things, right? So you need 10% reduction in nominal reduction in an absolute percentage stenosis, and you need a 0.2 millimeter or greater increase in minimal luminal diameter.
Okay, so you're actually talking about metrics for other imaging other than IVUS, and I'm about to talk about IVUS studies.
Can minimal luminal diameter measure? Danielle, you know more than me. Can minimal luminal diameter?
You can measure that.
You can measure luminal diameter with
Yeah. Okay, so let me just present this really quickly, and then you guys can go at it. So 2019 review, I counted 9 trials that, and these are in lipid-lowering intensive therapies, so various degrees of statins and some other cholesterol-lowering medication. I counted 9 trials with statistically significant plaque reduction measured by IVUS, various degrees. A lot of them, again, were down into the 50. So they brought patients down into the 50 to 70 LDL range. One example is the asteroid trial. From the asteroid trial, they say, quote, that it was resulting in significant regression of atherosclerosis for all 3 pre-specified IVUS measures of disease burden. Did you get that?
Yeah. So, Mike, I'm familiar with the asteroid trial, and I actually have the numbers for those metrics on the asteroid trial. And I can tell you that very few met either of those metrics. So very few patients met the metric of 0.2 millimeter regression, or which was 12.1% of the total. And then in terms of the 10% change in stenosis, only 7.5% of patients actually ended up with that regression, and I've linked the asteroid trial with those metrics in our disc conversation.
Okay, so we have, that's one, and then there's also the established trial. We saw 13.1% serial in terms of minus 13.1% in serial IVUS results. I mean, this one's doesn't appear.
Wait, 13.1% what, Mike?
Established. I'm just saying serial IVUS results. So I'm assuming that maybe
what does that mean?
I have no clue what that means. What he's talking about, I have no.
Okay, it's this is I'm the study that I just linked. I am in table 1, so I'm just going to look at the established trial. There's also a negative 18% one. Okay, IVUS assessment. Okay, percent change in plaque. It's percent change in plaque volume, I believe. So this is plaque volume.
Yeah.
But still, so you're talking about a measure for one, and I'm talking about a new measure using newer technology, negative 13% of plaque volume. I mean, that's notable.
Yeah,
and
but that's wait, Mike. Percent in plaque volume. Actually, when you look at the percent of plaque volume change in something like Asteroid, and you compare it to the other metrics, you actually get a greater percentage of plaque volume reduction for a lower percentage of stenosis. So now you're doing a different metric that's going to give you higher numbers. But when you actually standardize that to the other metrics, it's not going to look impressive. Like I can tell you right now, that number is not going to look impressive when you standardize it to those other metrics.
Okay, but I mean, I'm just saying that these people are saying that they are measuring rapid regression of plaque.
Question, Mike. So I understand, but I'll repeat the original question. So then, because I asked you the question, do you have evidence you can reject the criteria that is in the literature, but I asked you the question, within the criteria as it's defined, as regression is defined in the literature, clinically relevant regression, do you have evidence that a plant-based diet meets that standard? You've presented me with evidence has nothing to do with a plant-based diet that doesn't even meet that standard. So I'll just repeat the question. Do you have evidence for that, yes or no?
Do I have evidence for it reversing? No, I mean, I've already, I
no. Now you're just changing the question. You're not answering the question. With respect to cardiac disease reversal, as clinically relevant cardiac disease reversal, as it's defined in the literature, do you have
even
evidence?
Though this literature just defined disease plaque regression based off three metrics of IVUS, and then that's not regression.
It's not the same measure. It's not.
Mike, you're just not answering the question. Look, we can get into why we have that standard and why it's meaningful, and we can get into why both of those things are required. And I'm going to defend that standard, and I'll explain. I'm happy to explain why standards like that are actually valuable. But I want an answer to this question. With respect to that standard, as it is in the literature, as it's defined, do you have evidence that a plant-based diet meets that bar? Yes or no?
I've already said no, and I think okay, first of all, I would like to see it and see the full context of this, because it's possible that there are clearly other metrics with IVUS that these people are particularly saying there is regression of. And so I
Mike,
feel like you
not clinically no clinically relevant regression.
Right.
They can
we're talking about
Mike,
there's this literally
Don't you think pharmaceutical companies, if they could say that statins cause disease reversal, don't you think that would be on every single commercial? Have you ever seen anyone advertise, any doctor ever say that statins cause disease reversal? Have you seen Lipitor or Crestor or any company ever say, or a PCSK9 inhibitor? Have you seen any company? Don't you think they would be advertising? I mean, Avi's completely right. It does not meet up to the standard. If you actually look at it and evaluate it in the data as a whole, it does not meet the standard to true plaque regression. Otherwise, every pharmaceutical company for every statin on earth would be advertising it as disease reversal.
But you don't think the question is? I mean, these are really high level. I mean, just going back to Kim Williams, he said that there was plaque regression, but there were other negative effects at the levels of what they were taking. Is it possible that by the time you get to the levels required to get the results in these studies, based off that it's no longer safe?
We're concerned about clinically relevant plaque regression. If Kim Williams wants to say there's clinically relevant plaque regression in virtue of a plant-based diet, I'm happy to have a conversation with them.
But you understand where we're.
I don't think we should. I think honestly, leave Kim out of this and talk about your interpretation of the data, because it's not fair to speak for Kim Williams. He's literally like a brilliant, phenomenal cardiologist. I think it's just really important that you just interpret the data and don't speak for Kim, just in case. I don't think it's fair to Kim for anyone speaking for him.
Even if you were speaking for Kim, it would be just an appeal to authority anyway. Like, let's just talk about the data and what interpretation we can have from it.
Okay, so there's another. Okay, so I have another. Sorry, I'm looking through a lot of things here. Okay, 4.2. So you're saying that atheroma volume, rapid regression of plaque. Literally, okay, here's another study. I don't know if you're familiar with ApoA1 Milano.
I've heard about ApoA1 Milano, but what about it?
ApoA1, I mean, it was just another interesting quote from a study. Okay, ApoA1 Milano, for people that don't know, is a genetic mutation in the HDL cholesterol that was found in Italy, and a certain population has, they found like 40 people who had it, and they found that they had lower heart disease, so they were curious about it. They injected synthetic forms of that HDL into mice and saw rapid regression of plaque. It's the claim in this study that I can share right here, just so that you have it.
I don't know
and
why
then,
we would. Yeah, but I don't know why we would
This
entertain
isn't.
thing on mice. Then
This
this
is
is mice
literally-
data with people. I don't know what we're talking about. We're
no,
trying to talk about.
no. It's
No
not mice
clinical
data. It's
relevance
not mice
to human.
data. The idea is they saw
is
that,
it?
and so they decided to do in the Journal of the American Medical Association decided to do a trial, and again they talk about rapid regression of plaque. So I don't understand how rapid regression of plaque is not a meaningful metric, and that if it's possible
so
to have rapid.
Like, look. So number one, like this is so look, I have to look at the trial, but number one, it's not on a plant-based diet. We're talking about a completely different intervention. And then in terms of atheroma volume, again, that's minus 14.1 cubic millimeters. Again, that's going to be a 4.2% decrease from baseline. That's going to look even worse if you compare that to the mean luminal diameter or percent stenosis.
Okay, back to one last one, because there was one quote that I forgot to leave out on the statin studies. This one says that because I still feel like it's really important to establish that there is some type of lesion lowering ability of the body, and that this appears to be something that's happening, and we need to study it more. Fine, but I want to just understand so you guys think it's possible, but in my opinion, it has been more established than perhaps you guys are making it out to be. I mean, we have this study going back to one of the statin studies. I believe this was, these are, you can just read, there's another table too. High dose statin reduced plaque and fibrofatty volume, meaning that it might correct me to say that that's wrong based off IBIS. They actually saw a reduction in the fibrous/fatty volume of the lesion. So that is
totally possible. But but whether you would call that clinical disease reversal is not the case. That person would off their statin. That is not disease reversal. Of course, plaques. I mean, statins do plenty of things to stabilize plaque, to do important things with regards to lowering LDL. But that we would not call that disease reversal.
But if things like this can bring a certain portion of the population over the threshold to the point at which you would consider them having disease, maybe it's 10%, maybe it's 20%, or if someone has 10% and some 10% stenosis and they're able to reverse it, and we know these mechanisms of exactly how it's happening.
But that doesn't. That's not disease reversal.
Wait, 10%. Wait. Where did they meet
10%? I'm saying theoretically, if you're able to get some, and there was 10%. Or has there not been 10% in any of those?
No, you're talking about 10% in stenosis percentage? No, you're talking about atheroma. You're talking about atheroma volume. That's not the same thing.
But then, okay, so here's my question. So when Dr. Esselstyn's study got up to like 8%, it's almost there. It's a gradient of adherence.
That's wait. What do you mean 7.8%?
Wait, okay. Let's actually look at the study before we start making claims. You're talking about absolute. Yeah.
Yeah, absolute percent.
Okay, sorry, I was talking completely from memory. So this is a spectrum of adherence, though, and this is why I would argue that there's good evidence, because if you look at
even if you looked at the most adherent, Mike, it didn't. They got up to like maybe
7%, 6.8%. I mean that.
Yeah, it didn't meet the bar. Even if you cherry pick the quote unquote best performers, they still don't meet the bar as defined in the literature.
I mean,
you don't get there. And if you look at the 95% confidence interval over the mean, you still don't get. Maybe you get even half of there. And by the way, here's the main point. If you look at the mean luminal diameter, it's literally at the 0 mark. You would have to go a factor of 20 to get higher. And if at 5 years out in the Ornish study, you would have to go a factor of 200 out to get out to clinically meaningful results as defined in.
So this is where I feel like there is a difference between Esselstyn and Ornish's studies. Perhaps I'm wrong, but I believe that Esselstyn's treatment of, for example, using just having a more particular regimen than Dr. Ornish could have come up with more intense results, and that's why we see.
Do you have the mean luminal diameter values in the percent?
But that's what I'm saying. Is okay. So we're talking about different standards. Fundamentally, we're talking about different standards of what is heart disease reversal and what is not. I'm saying that between all of the information that we have, all of the people that have cleared out arteries on angiogram, and you can tell me why perhaps they didn't, in addition to how we're seeing removal of fibrofatty tissue in people who got their LDL in studies with people who went
You're
down
not
to that.
seeing removal. You're not seeing
Mike,
removal.
you're
of
not. Mike, can you
hydrophilic-
answer the question?
Reduction of
Can you answer the
fibrofatty
question?
volume? Where does it go? Where
Wait,
does it
I'm
go?
sorry.
if you're not-
We can't say removal. I'm sorry. We can't even just like we can't. It's just this is too much. This is very
Wait,
unscientific.
okay, Mike, right. Let's
Okay,
keep
can I
it
read you?
structured,
Can I
guys.
read you one sentence from one study, please, because it's very relevant, and then I'll let you guys
Go
roast
ahead,
me.
read
Anyway,
the
okay.
sentence, and then
So here's
and then I
2019
want
in
you
the
to answer
journal.
my question, though.
2019 in the Journal of Atherosclerosis and Thrombosis. Plaque shrinkage is a coordinated process that involves the depletion of foam cells and extracellular
Sure.
cholesterol stores, a gradual decline in macrophage numbers through enhanced emigration from the plaque, and the replacement of inflammatory macrophages with anti-inflammatory phagocytes involved in the removal of necrotic material and tissue healing. And I believe, okay, here's another one, Clinical Lipidology 2014. Macrophages expressing scavenger receptors remove modified LDL, and HDL finally removes cholesterol
Sure.
from macrophages and delivers it
That's
back
a
to the liver.
That's a
great
great
mechanism.
mechanism,
Wonderful
right.
mechanistic, great mechanism. We want to know if it results in clinically significant outcomes. Now,
But when I just
When-
mentioned a study where fibrofatty volume was reduced, and then the mechanism for
Reduced.
how it happens,
yes, so
I
that
don't
does
understand how
not.
you
That
can
is
then say
not-
that.
That's
you know,
not clinically relevant cardiovascular disease reversal. It could be great. It can result in less CVD outcomes. It can
Yes.
be all sorts of things.
Correct.
But there is a specific standard, and we can go into why we have that standard for what is cardiovascular disease
Let's
reversal
go
as
into
it's
the
defined in
standard. I think
literature.
it's about time.
Yeah.
Why don't you start covering that? I think that's really
Okay,
important.
and before and firstly, but I want an answer to this question. So you tried to pivot away from the Orner study to the Esselstyn. Do you have the mean luminal diameter and percent stenosis values for the Esselstyn study? Yes or no?
they're not made available.
They're not. Okay.
That's correct.
So the only thing we have available to look at percent stenosis that's been changed or MLD is the Orner study. Is that correct?
Yes.
Yes, at this time, but
I already know the answer is yes. It's okay. Okay, and now let me ask you this. Here's a question for you, Mike. Do you think with no change, first of all, do you know how percent stenosis is calculated?
I just want to mention really quickly that I just want to ask you what you think about the 39 people literally listed as reversal in Esselstyn study. Do you just say
yeah,
we don't know the number,
yes,
so you reject that?
I don't have the number, so I don't know that they meet the bar for as defined in the literature as clinically relevant reversal. It can call 100% of them reversal. I need the numbers. Now, my question, I'll repeat the question back to you because it hasn't been answered. Do you know how percent stenosis is calculated?
In terms of the percentage
of the values that are reported.
of, is it the percentage of the stenosis that's blocking the artery, or am I wrong?
Do you know how that's calculated? I can tell you how it's calculated. So I'll post this in the
Is it
Discord.
diameter? Is it diameter, ratio of diameter to
It's
stenosis?
A over B. So it's the minimal. So it's the minimal luminal diameter divided by the reference diameter. That's how it's calculated. Okay. Now my question to you is if you look at that ratio, do you see it on screen?
Oh, okay. I'm off here. Okay. Yeah. So, okay, no, that's my study. Minimal luminal diameter.
We'll get
Okay.
I'm just gonna come in for 1 second here. So you're talking about things being shared on screen. Keep in mind, unless you actually screen share, it's not going to show up for the people seeing it. So if you want the audience to see anything, you have to actually use the screen share function.
Okay, that's fine. I'm gonna screen share then. Okay. Let me.
I'm trying to wrap. I'll let you finish this thought, but I'm trying to wrap my mind around like.
So
when you have. Okay, just finish this. Yeah.
While I am butting in for a second, I'll just ask one other thing. Does everyone so far feel that they've been able to get what they want addressed? Mike, Danielle, and Avi, do you feel that you've been able to get answers to what you've wanted to get answers to? I know that was Mike's concern going in. I know you guys.
I mean, I wish I was able to look at the source and all of the research and the full context of this 10% figure, but that is what it is.
Because I hear
some.
This will be the final thing I'll say, because I hear some quibbling over. I heard Mike trying to get an answer to something about 35 people. I heard Avi trying to get an answer to something. So I just want to issue a reminder. If you feel you're not getting an answer to something, we want it to be a fair conversation. Just mention that you want moderation or that you want to get a clear answer, and I can come in and ensure that. Sorry, go ahead.
I answered the 35 My answer to the 35
Right.
was that without those numbers, I actually can't comment on whether they actually meet the bar or not. Okay, so now getting to the standard, I want to actually give another question to Mike. So if we take a look at how percent stenosis is calculated, which is the minimal luminal diameter divided by the reference diameter, you'll notice that percent stenosis can increase in a number of ways. A can get larger, B can get smaller, or a combination of the two. Now, here's a question I'll ask. Mike, would you consider if all of the increase in if all the decrease in percent stenosis can get smaller, sorry, if A gets larger, B gets smaller, or a combination of the two. So my question to Mike is, if all of the percent stenosis decrease is coming from a decrease in B and no increase in A, so that gap you see where the artery is there, that's actually
You're saying a decrease in diameter.
Up. Yeah, increase in the reference diameter. Decrease in B, which is the reference diameter.
Yeah.
Do you see what I'm looking at, the figure?
Yeah. You're saying B. You're saying that if you just shrink the size of the tube, you are able to increase the percent stenosis. I don't know what you're talking about.
If you decrease the size of the reference diameter, you can actually spuriously decrease the percent stenosis if there's no change in the minimal luminal diameter. Now, my question to you is, if you had that, would you consider that reversal of plaque?
You're just saying if somebody was just trying to hack the ratio, would that be reversal? That's what you're asking me.
Not trying to hack. No, not trying. I don't care if they were intending to do it or not. Not quite. My question is if that's just what happened. If what happened was the reason the percent stenosis decreased was because the reference diameter decreased and which is the minimal luminal diameter, did not change, would that be considered reversal on your view?
I mean, I don't even see why this is relevant, but I don't think. And I mean, you're literally talking about it too.
It's very relevant. It's absolutely relevant. So what's the answer?
You're asking me if decreasing the diameter of the tube, or increasing or decreasing or setting the baseline for a diameter of the tube has anything to do with what the actual cloggage of the artery is? No.
My question is, if you had a decrease in your percent stenosis only because your value of your reference diameter decreased and your minimal luminal diameter did not increase at all, would you consider that a reversal of CVD?
So you're saying that as the tube grows, but the distance between the two remains the same, is that reversal or not?
I'm saying as the reference diameter decreases, but the minimal luminal diameter actually doesn't change, is that disease reversal?
No.
Still, okay, good. Good. Now that's what happened in the Ornish study. If you look at the minimal luminal diameter, it was practically sitting on the zero. At 1 year, it was 0.01 change, and at 5 years, it was 0.001. In fact, the change in stenosis was spurious. It was only a decrease because the reference diameter decreased. The reference diameter, not statistically significantly, but it decreased, and that was enough to.
So if it did statistically significantly decrease, then how is that meaningful?
No, but that's still the way the math worked out. It changed enough such that the percent stenosis calculation worked out to be statistically significant. But the key point here is that it wasn't a change in the stenosis in virtue of increasing, in virtue of the minimal luminal diameter increasing. It was just a change in stenosis as a result of the reference diameter decreasing. Let's look at the table. Look at table.
Okay, yeah. I'm looking at the table, and I honestly, just because of just the level of just chartage and stuff that's going on, I feel like this is a good question for Ornish, because, I mean, we're seeing, like you're saying again, not statistically significant variations in one, and then minimum diameter.
I'm gonna come in one more time to say something, which is that, Mike, you might want to actually look at Avi's screen share, because then you can see where his pointer is, and you can see exactly what he's pointing at and where on the study, instead of tracking through it yourself, trying to make sure you're looking at the same
exactly
thing.
Where he is, and I understand what he's saying. I'm just saying that this is like like I'd need a second to actually look at the numbers instead of just immediately knowing. But I understand. Okay, so you're. I mean,
point out that if you look at the confidence interval, it's literally just as much in the minus as it is in the positive. Like your point estimate is literally at the 0.001. It's almost literally at the 0. The 95 confidence bounds are 0.11 and positive 0.11. Negative 0.1, positive 0.11. Your minimum luminal diameter is not changing at all.
Shrinking. Okay, but here's my question though. If there is a true, you're saying there's just a difference or a change in your B? Because if your B shrinks and your A, no, I'm looking at this again, and maybe I'm incorrect, and again, this is very on the fly. But if B shrinks and A is not shrinking, then you would actually have a lower volume of the stenosis of your little red area.
That's only if the change in B reflects the segment of the change in the reference diameter of where the plaque is also. So you have to measure. So so again, like when we're looking at these numbers, we're looking at it at a scale of like the millimeters that are changing here. It's at a scale of 0.001 or whatever. Like you're looking at a 0.01 millimeters. At that level, like any fluctuation in any segment of the artery can give variation at that point. So it's not necessarily the case, because if you have a reference diameter that's not where the plaque is, and then you have a fluctuation there which is not met by a respective same fluctuation where the plaque is, you can just have a decrease in the reference diameter and not have a decrease in your minimal luminal diameter, and you can just spuriously have a change in stenosis. We're talking about, and especially when we're talking about tiny numbers. So this is why it's so important to have an increase in the minimal luminal diameter. This is why in the criteria, getting back to why we have that standard, the reason why we have both of those things in conjunction is because you don't want just your stenosis change to just come from a decrease in your reference diameter. You have to also have a change in your minimal luminal diameter, and that makes sense because that's what's stopping the blood from getting to the heart.
Correct.
Yeah. I mean, I'm ready to move this. Like, I honestly, I would have to just look at this longer and actually do, just spend more time with it to have a real answer. So, I mean, you can consider it I'm wrong on that one or whatever, but I still feel like asking Ornish or talking to people who, I'd just be curious to see if, if you told Ornish, hey, your percentage is.
If you wanted to talk to people that are. Yeah, I think talking to Dr. Ornish is great, but I think the best people to talk to are some of the cath experts. Look at cath research and cath data nonstop. I can catch up with many of them who've evaluated the same literature and have come to the exact same. And we're not going to appeal to the authority. I know that Avi hates that, but I've discussed this exact literature with I presented this study at Journal in front of numerous cath experts who do cath in and out, and Avi's that he explained to you. It's just what the data shows is accurate, because that is the standard of evidence. I mean, I know that this is kind of a detour, but Mike, the reason why I think it's an important fact is, don't you think just on the basic general principle of statins, don't you think that if using that same criteria, if we would be saying statins cause disease reversal, why wouldn't we be doing that?
I do believe that it's more of a full body change as well. It's a lowering inflammation. Maybe, I mean, you probably get lowering inflammation with statins too as well. But I also, perhaps it's, like I said, the level of statins that are required. These are the highest intensity therapies to get down to that 50 or whatever LDL, that perhaps it is so negative, the results are so negative, as I don't want, because, okay, I don't want to say back to Kim and say that he said, but he literally said that there's a lot of bad outcomes in that study about measuring the regression of plaque. Another one that I didn't even mention here because it wasn't IVIS, so I didn't think it was up to your standards. But if there's so much negative side effects that would possibly happen to get there, they wouldn't be able to say that you can reverse it in a normal dosage. I mean, that's a possibility. I just can't rule it out.
We agree it's a possibility. We agree that reversal is a possibility. I'm just saying that none of these studies actually showed that a plant-based diet reverses cardiovascular disease to any clinically meaningful degree, even on your standard, which you just agreed to right now by agreeing that there needs to be an increase in the minimal luminal diameter. Even on your standard, you would agree that it's not clinically meaningful. What did you just agree to? I asked you the question.
There needs to be an increase. Okay. Here's a question. This is why there's just a lot of information coming at once. So, like, if I say something and maybe I flubbed up, but We're talking about minimal luminal diameter where there is no stenosis. Is that not a reflection of dilation?
We're talking about the
Or
minimal
disease?
luminal diameter, and that
Minimal.
could be
Okay,
a
minimal.
couple of.
Okay, yeah. No, it's
Yeah. So
Okay.
that could, you can increase the minimal luminal diameter by.
So
There's a
here's
couple
my-
ways you can.
yeah, through dilation. If someone has more dilation, you can increase the minimal luminal.
Yes, I agree. Yes. So that's why there's two things that need to happen, right? So two things that need to happen. That's why you have in conjunction. It's not just the increase in minimal luminal diameter to say there's clinically meaningful reversal of CVD. Otherwise, we would just say the reductio for that would just be that if there's a dilation, we would say there's CVD reversal, and clearly not. You need both. You need to show that A, there is an increase in minimal luminal diameter, and B, there is a decrease in percent stenosis. Because if you just have a dilation, guess what's going to happen? Your minimal luminal diameter would increase, but your percent stenosis wouldn't change, because A divided by B would still be the same.
Yeah. I totally understand that, but I'm
So
still stuck on the point where there's so much happening in the human body when people are shifted to from a standard American diet to a plant-based diet, where there's decrease in inflammation. You're talking about a decrease in LDL massively. You're talking about various things, a full system change that happens. And I just feel like, okay, you're standard. And maybe mainstream medical standards is 10% or bust. But it seems like based off seeing the what I consider to be astounding change in outcomes, people no longer having what in their life is heart disease, and also seeing regression.
But Mike, now you're just going
for the average person though. Like I'm just
That's not for the average person. That's not. I'm sorry. I have to jump in. So that's not how. So that's not how we define. That's not scientific. That's not how. What is for the average person is defined as symptom reversal. We have to make this clear. The reason why this is important is because the average person. I do not expect the average person to understand the medical terminology, but symptom reversal is not disease reversal. And I could not agree more that a plant-based diet does so many important things in the body. I am the biggest proponent of a plant-based diet. But and you know what? Who knows? Maybe our study we do looking at cardiac CTA, maybe the person who's on the carnivore diet is telling the truth, and that reverses CAD too. Bottom line is that it hasn't been studied in a way that has shown at this point that there is true disease reversal from a cardiac disease, coronary artery disease standpoint. Symptom reversal and disease reversal are not the same. And yes, definitely more research needs to be done. Our group is 100% planning on doing it. And I think that all of us actually really agree on a lot more than we disagree on. And I think that is really true. But I think that the data here, it's pretty inarguable. Otherwise, we would all be saying statins cause disease reversal, which actually doesn't even meet that criteria anyway. And same with diet. It's not clinically significant up to the standards, like Avi said, that's defined in the literature.
Okay.
And again,
I would love to be sent. I would love to be sent the literature because I still haven't seen.
I sent it. I sent it. No. I sent it in this call. Like this is the standard.
Okay, there's no label of it.
Here, I'll send it again.
American Heart Association one?
Yeah, the AHA journals. This is when in the asteroid study, which you actually mentioned, by the way, when they looked at Crestor, when they looked at rosuvastatin, they wanted to see what a standard to judge it by what clinically relevant regression would be. Sorry,
so I have another question. Do you believe that you...
Sorry, Danielle, we're getting crazy feedback through your thing.
So if you have somebody who has issues with their heart, and this is where it would be interesting to also talk about other parts of the cardiovascular system, but I won't, where they have an issue where when they go on a high nitrate plant-based diet, they are able to then get the equivalent increase in blood flow that they would get from a removal of stenosis. And this is where I wanted to ask the question, do you feel like there's, I guess I can't use the term reversal of heart disease, but do you feel like the clinical effects of that would be the same as reversal? Like, let's say there's somebody who doesn't have heart disease. You look at them, they don't have heart disease, but they have, maybe they're a little bit older and they have poor nitric oxide production.
I'll just answer right away. Yeah, sure. Go ahead.
Okay. So they have poor dilation of arteries. They're older. Their nitric oxide is bad. Maybe their endothelial cells aren't functioning great, but they actually have really low stenosis. They don't have heart disease. So my question is, if you are then able to put them on a plant-based diet, and then, or sorry, they do. I don't know if you would consider that heart disease or not. If they have not very functional dilation, is that a type of heart disease? I mean, do you consider that heart disease or not?
Mike, I'll answer. Here's what I answer. I know what you're trying to get. I think you tell me if I pick up what you're trying to get.
She back.
No. So what you're trying to say is, let's say you can have a plant-based diet, and although it's not called reversal as you're defining it, let's say the outcomes are actually better. Let's say their outcomes are like just amazing. My answer to this is yes, you can have amazing outcomes on a plant-based diet. And you can actually have. Here's the get ready to gonna blow everyone's mind. Ready? You can have reversal of disease and have worse outcomes. You can have progression of disease and have better outcomes.
Yeah,
these things are tangential. Yeah. So
but
you can go on a plant-based diet. I agree. You can go on a plant-based diet and the outcomes could be great. The symptoms could be great. All that's being said here is that it's not reversal. That's all.
Can I just ask my question though? If somebody has an issue with their endothelial cells, they do not have stenosis, they have an issue with their dilation, is that a type of heart? Would that be considered heart disease?
You're talking about like vasospasm? Yes, microvascular heart. Are you talking about
cardio? If they have an issue with dilation, is there a type of heart disease that would be classified as dilation?
But it would. And discuss the classifications of heart disease. So we have different kinds.
Sure,
of heart
go
disease.
ahead.
You can have coronary artery disease when we're thinking of the epicardial. So your epicardial coronary arteries. So what we've all been discussing here is we're talking about epicardial coronary artery disease. We're talking about your left main, your circumflex, your RCA, and your LAD. That is what your PDA. This is what we've been discussing here is epicardial coronary artery disease. You can have microvascular coronary artery disease, which is, you think of like tree branches and the roots of the coronary arteries, which we can't diagnose in cath. That you can use different imaging studies, but you can't really diagnose in cath because it's smaller, etc. So yes, I fully agree that there's many plausible benefits of plant-based nutrition, as well as, we use nitrates for these patients too with microvascular disease. Different kind of disease process, but people can have the same way that nitrates, dietary nitrates, or even we give IMDR or you give calcium channel blockers. There's different medications you can give that can improve the symptoms in both. But the benefit of plant-based nutrition is that, of course, as everyone here on this exact phone call agrees, helps improve mortality outcomes, things like that as well, which is important.
So my question,
to answer your question, Mike, I'm going to answer your question. Yeah. What? Wait, I thought you asked me.
No, I was going to ask a question. So if you have a type of heart disease that is inflammatory based, caused through inflammation and or a lack of the artery's ability to dilate, if you then go on a plant-based diet and make those changes. So yeah, you can't, maybe if you can't reverse heart disease, I'm just trying to ask, is it possible to then reverse those diseases that are not stenosis related because you have changed the body's ability to lower inflammation and you've changed the body's ability to dilate your arteries by improving endothelial function, perhaps through nitrates or just an improvement of overall health or lowering of inflammation until the point where they no longer have that disease? That seems like a plausible way to reverse that type of heart disease.
I think it's a dangerous. I think using the term disease reversal is just makes me very hesitant without. We don't have data for disease reversal, meaning if it improves symptoms, and the thing is that we can just say things like that it does is improve symptoms or improves 6-minute walk or improves whatever we know, all these different things. But disease reversal, we don't even know. We don't even know truly. Actually, there's even debate in the space of diabetes, which is even more defined with even hemoglobin A1C. If someone improves their diet, is it remission? Is it reversal? There's like a whole debate in that space as well. So to say that it's reversal because someone has symptom improvement, it just goes back to semantics. It's just their symptoms are improved, which does not minimize how important that is for quality of life. That's incredibly important. But you have to understand, so from a physician's perspective, okay, someone has CAD, or even if you've ever had a cardiac risk factor, so even preeclampsia, for example, which is something that you've had a baby, preeclampsia is over, okay? That is still a cardiac risk factor for the rest of their lives. And as a cardiologist, you have to take that into account for their cardiac risk. So once you've had heart disease, you always have to take that into risk. So that's why symptom improvement's important, but you wouldn't just say complete disease reversal. We just don't have data for that.
Okay, so in terms of what somebody in the field of cardiology says about that, but my question is, it seems as if there is a situation where it is physically possible for somebody who has a type of coronary artery disease again, even under your metrics of saying plaque reversal and all that stuff is not possible, or has not been proven, sorry, has not been shown, that you can reverse heart disease based off, it is possible if you can, through lowering inflammation and improving the function of those people's arteries function in their heart to the point where they no longer have that disease. I just feel like in terms of
listen, I agree it's possible, Mike. I agree. I'm always going to agree with you in saying it's possible, but in order for us to make the claim that this is what it does, I just need actual data. I need rigorous data to actually show that, or I need something to really show that, not cherry picked caps or whatever.
The difference is that you have a standard of evidence that is, we need a randomized clinical control trial that shows 10% or more reversal or lowering of stenosis, and I am still
on my standard and your standard, Mike. Don't try to say it's not on your standard, because I showed you I showed you this too. I showed you even on I gave you the reductio.
No,
and everything.
I'm actually from again, you say it's not semantics. Like, Danielle, you're the professional. As a professional, you can't say it's reversing heart disease, but when you're talking about the average person and what is going to happen in their life and what going on a plant-based diet will do for them, when you're talking about them going from somebody who functionally doesn't know that they have heart disease to being somebody who is as they were as a fully functioning human being who is able to do all the healthy things they did before they were diagnosed with heart disease, there is, like, to tell people, the average person, that is not reversal just seems, even though there is a technical definition, just seems incorrect.
So okay, so let's just first of all just get one thing straight. So if what you mean by reversal is you just mean that symptoms have improved, if you not, and I want to say just because it's not belittling it, it's meaningful. If that people that it will change outcomes and symptoms, then I will agree if you have that proprietary definition of reversal. But if what we're talking about is something very different than that, we're talking about the actual disease process, if it's there or not. Now, I can get into why it would be problematic to call it reversal. We can speculate as to why. We can get into the conversation of why I don't think we should call that reversal.
Okay, no,
and why even for the layman we should. Yeah.
Okay, and okay, so I have to jump in here. It is not, you cannot call it reversal when it's not scientifically defined as reversal, because we are not talking about what comes from physicians is what gets trickled down to the layman, right? So you can't just call it reversal to the general public and then physicians don't call it reversal, because what it comes down to is, for us, is what changes medical management. Okay, if someone has complete disease reversal, that means they don't have a disease anymore. And
no, I've never said complete disease reversal. I'm just saying a meaningful disease reversal.
I mean, we haven't seen that anyway. We haven't seen meaningful disease reversal in the scientific literature anyway. But to say disease reversal gives people the impression that changes medical management. It does not change medical management. A 3% or whatever.
Yeah.
And what is key here is a medical and procedural therapy. It does not change. A plant-based diet, if you have known coronary artery disease, does not change medical management with regards to, maybe we could reduce the statin dose, but they'd still need to be on a high-intensity statin if they have known CAD. But, and they still have to be on dual antiplatelet therapy if they've had a stent. This is the thing, is it does not change clinical management so not only for the physician, but for the patient. So meaning a patient who has established coronary artery disease does not go on a statin and go on a plant-based diet and get to go off their statin once their LDL is normalized. That is it. So it doesn't clinically, so there is no meaningful clinical difference that changes medical management. Symptom improvement, wildly important. I take people off of nitrates. I have patients with angina who go on a whole food plant-based diet, they lose weight, and they are able to decrease the nitrates they're taking, their IMDR, and their symptoms improve. That is so important. And both me and Avi think quality of life and symptoms are incredibly, incredibly important. But when it comes down to the hard things of primary and secondary prevention, it does not reverse disease. Because if it was true disease reversal, then we would be taking patients off of their medication. If someone's heart disease was gone and then they go to their doctor and they say, why am I still on my statin, my beta blocker, my Plavix, my aspirin, and my Entresto when my disease is reversed? No, your disease is managed.
I still just want to say that I do not equate disease reversal with disease curing. I don't, because that was, again, and then you said again that hasn't been shown. But here's one of my just intuitively how I feel, and maybe this is just wrong from a public health perspective. You have these people seeing these, what I consider to be pretty amazing results, and say the Esselstyn study 20 times less than the normal rate is what I calculated, of adverse events, and you see these angiograms year after year, new ones coming out. Esselstyn has his new one. Various people, Baxter, Montgomery out there sharing his, and then you tell them that's not reversal of heart disease, and you need to, like, everyone needs to be on statins for the rest of their life. Like, I understand the validity of that statement, but
I also okay. So
I feel like
it's not that everybody needs to be on statins for the rest of their life. I think there's also here, Mike. There's also a difference between your I'm not trying to be facetious, but there's a difference between your understanding of level of evidence and me and Avi's. Meaning the difference in the level of evidence that it takes for me and Avi as physicians to say,
and I wholeheartedly agree with that.
This
yes.
is what is clinically relevant
Yes.
to our patients and to the general public is different. So you would take a case-based anecdote and let that change what you use as a terminology for the general public. Me, as someone who cares very, very much about what the public says too, I do not feel that way. In order for me to say something works for the general public, we do need robust and rigorous research. Otherwise, we'd still be giving patients hydroxychloroquine right now for COVID if we went by cases and individual anecdotes. Do you know what I'm saying? It, like, good science is required for us to not only just treat our individual patients, but for people as a public health in general, meaning that, like, we cannot just go by small case reports, because the thing is that you can literally improve. I am not taking away from the possibility that yes, some people have had, maybe someone has had clinically meaningful disease reversal with X, Y, or Z diet. That's wonderful, but do you know what I'm saying? I mean, the level of evidence that you require to make such a broad statement is different than the level of evidence that Avi and I require with regards to, you know, public health measures and what we want the public to understand, because we care about what people understand that's going to be safe for them and harm them. You want to motivate people to follow a whole food plant-based diet. I couldn't preach that enough, but I will never say to them that it reverses their heart disease, because we do not have that data, first of all, and that also gives people the wrong impression that they can go off of their medications, which is dangerous.
But if you do complete your study and it does show that it reverses heart disease, you will then be saying, yes, it does appear to reverse heart disease.
I would
Well,
love
we'll give you a
nothing
goalpost.
more.
Yeah, listen, Mike.
I would love
I'll give you.
nothing more
We would
if
love
you
it.
show that. I would love. I mean, for me, someone who is literally dedicated everything I can. I mean, I care about animals more than anything, but I really want to stay true to nutrition science. I would love more than anything. I will admit my bias right here now. I would love if I do a cardiac CTA study and it shows that a plant-based diet blows away coronary artery disease. And, you know, at the end of the day, would I ever take that patient off of a statin? Absolutely not, because it's not going to take their plaque down to zero, and plaque stabilization is important. And I care about my patients living longer. I don't care about winning against pharmaceutical companies or anything like that. I want my patients to live the longest, healthiest lives. So we have to do that in a scientific and fair way. And let me just give you, I know we're not talking about anecdotes, but let me give you two anecdotes on the other end that really may impact you. Okay. I want to give you one that's really important to me. I had a patient of mine that came to see me for a second opinion because he had triple vessel coronary artery disease, including a left main lesion that was almost 70%. He was under the impression from YouTube and from plant-based nutrition, et cetera, that he could reverse his coronary heart artery disease with a plant-based diet. He refused to be on the statin and aspirin. He came to see me. At this time, I was a fellow, a cardiology fellow, so I saw him with a preceptor, who was an interventional cardiologist. We pulled out his cath. We told him, absolutely not. Not only do you need to be on your dual antiplatelet therapy, you need to be on a high-intensity statin, you need to be on a PCSK9 inhibitor, you also need coronary artery bypass surgery. We have a left main of 70%. Okay, he had an LAD that was 99%. We told him you need bypass. This is based on very rigorous guidelines. This patient was like, I absolutely will not have bypass. I can reverse my disease with plant-based nutrition. Goes on a whole food plant-based, no oil diet. We document in the note as many times as we can. We advocated for guideline-directed medical and procedural therapy. The patient said no. He had a massive, massive heart attack last July. Ended up with an ejection fraction that was originally 55%, ended up with an ejection fraction of 10% and is waiting for had to get an LVAD and is waiting for a transplant. I mean, so it's really devastating what this kind of information could do. That's an anecdote on the other end. Okay. So that is one of many anecdotes of why I care about us being really careful with the terminology and making sure that yes, everyone on this earth should be following a plant predominant or plant-based diet. And that's in our cardiology guidelines. We recommend plant predominant diets, but we also should be following guideline directed medical and procedural therapy. And we should also be careful about the way we use terminology with disease reversal, because people think that it can reverse their disease, and that is not the same as reversing symptoms. Does that make sense?
Yeah. And I think it's really unfortunate that people would also reject Western medicine because something may or may not do that. And I just want to mention one last thing of that. So the quote that I see in literature and that I've mentioned before, I believe it was Tom Curley paper or whatever, says a plant-based diet is the only one clinically proven to reverse heart disease. So that is just, I mean, you understand how like these things do appear in the literature.
Yes.
Yeah, it's unfortunate.
It's
very
so
unfortunate.
And in Esselstyn's study, 39 people showed reversal of heart disease, and then we see people all the time.
No, we don't know.
No. I'm talking
Wait,
about
wait,
that being written. I'm talking about that being written.
Oh, that being written.
Oh,
Yeah.
yeah,
No, it's
yeah.
unfortunate. I agree. It's very unfortunate
I
that
couldn't
it's
agree
very
more.
unfortunate it's written without actual justification.
And
Trust me,
then
I couldn't agree
the
more.
semantic difference, and then on top of that, the semantic difference between somebody's life experience of their waking up that day and in their life, as far as their personal experience is concerned, hundreds of people have reversed their symptoms. I'll say that, which appears to them in their life experience is reversing their disease, their personal understanding of their disease. Unfortunately, you're saying that's leading to people to not want to go on statins or whatever. But you see
Right,
where
Mike,
I don't want to say
Mike,
that you're.
Mike, from a doctor's
Yeah.
perspective, though, there's no doctor on this earth who thinks the symptom reversal with regards to coronary artery disease is the same as disease reversal. Symptom reversal and disease reversal are two totally different things. We see this heart failure as our classic example. I know it's confusing because there's so many different mechanisms, and I'm going through all of them, but symptom reversal and disease reversal are both very important, but they're different. And so that's why it matters, because they have two different implications.
And
two
Mike, I
different-
gotta tell you, I just gotta tell you, I cannot begin to tell you, when I tried to make this case to the community, that a plant-based diet, so if you have known for secondary prevention, if you have known CVD, a plant-based diet is great. It's not a replacement for a statin. You have
Not at all.
no idea how many.
Yeah.
You have no idea how much pushback I've gotten from the
It's
plant-based community.
unbelievable.
And do you know what they say? Do you know what they say when they give me that pushback that I can go off my statin? You know what even if they had a heart attack, even if they had CVD, they say the Ornish paper showed that and the Esselstyn paper showed, and they had people with heart attacks, that it reversed their disease. And I'm going to go off my medicine. That's always they say it time and time again. It reversed the disease. I'm going off my statins.
And
I can give you tweet quotes from this.
And let me tell you, and the idea that you cannot go off your statin is not based on my opinion or Avi's opinion or anyone's opinion. This is based on the American College of Cardiology guidelines, which are based on, it's not, and Kim Williams, who I love, who's brilliant, he is on the guidelines committee, but so are like 30 other brilliant cardiologists across the country, including Erin Mikos, Ron Blakenstein, like all these people who are super smart, Roger Blumenthal, all these people are creating these guidelines based on tons of meta-analysis, systematic reviews, all of this robust research. There's a reason why we recommend for secondary prevention, people remain on their statins, not just their statins, but their aspirin, other medications too. If you're on heart failure, the other misconception, while I have everyone's ears, that people have is that once you've improved your ejection fraction, people think that heart failure patients, they've improved their ejection fraction on plant-based diet. That's wonderful, that they can go off their heart failure medications. You can never go off your guideline-directed medical therapy for heart failure either. These are the reasons why I have seen, me and Rob Osfeld, who are very good friends, has seen the sequelae of this misinformation in the plant-based community. We receive these patients who come to us, and then we have to say to them, not only are you going home on one medication, you're going home on 4, and you need a bypass, and you should stay on your plant-based diet, because I want people to live longer. It is so devastating to think that it has to be all or nothing. And I think the terminology that's used about disease reversal is very, very confusing for the general population.
Okay, so let me just sum up where I'm at. So I have no problem admitting that based off what you've sent me, we have yet to demonstrate that a vegan diet has shown to reverse heart disease, but with the caveat that it is not proven to not reverse heart disease, and also that there in the future it is this is my view, is I still believe that it is likely, and maybe you don't believe that it's likely, it is likely that future studies will show the reversal based off mechanisms that I've read about,
I hope
based
so.
off angiograms they've seen. Yes, and
I
so I
hope
think that's the
so.
place.
Listen, I hope
And then
so, Mike.
finally, final point,
I hope you're right.
and then finally that the clinical definition of reversal of heart disease and the colloquial definition of reversing heart disease and experiential difference of reversing heart disease are different things.
Right.
And so that, well, one
Yeah.
is so that they're both, I know this can sound annoying, that they're both technically correct. There's one that's
No,
medically
no,
correct
no,
and
no.
one that's not medically correct.
No. There is no
Why-
physician that thinks symptom reversal. I'm sorry. There's no physician that would tell their patient symptom reversal is disease reversal. I can understand how that's confusing for a patient. I can totally understand how that's confusing. But there is nowhere in the scientific literature or with physicians in general that believe, with regards to heart disease, that symptom reversal is disease reversal. We see this with atrial fibrillation. Just because someone's symptoms go away doesn't necessarily mean their AFib goes away. Their AFib goes away if we put a loop recorder in them and we see they no longer have AFib. They could have no more symptoms because we put them on a beta blocker. You see that it's very.
I just had another thought. Sorry to
Okay.
interrupt. So if you have somebody who has, sorry to just jump to another disease, but somebody who has cancer and they have a tumor and their tumor shrinks in size and their symptoms go away, would you consider that a reversal?
I'm not an oncologist.
Not curing, because reversal, I'm talking about reversal being an incremental step in the back direction from what occurs in the disease process. That is a reversal.
I'll answer that. Yeah, I'll answer that. So if there was a standard guidance for what degree the tumor had to reverse and whatever criteria that needed to be met for them to consider it clinically relevant reversal, and if it met that, then yeah, I probably would consider it. But if it did not meet that criteria, so if it reversed by a few cells, or if it reversed by 0.001 millimeter, I would not consider that clinically relevant regression if it didn't meet the criteria as published and what the criteria is for clinically relevant regression. That's my answer.
Okay, so I feel like, and maybe I'm wrong, but it seems like there's a clinically relevant definition within a certain area, but I still feel like because reversal is not curing, reversal is not getting rid of a disease, reversal, I feel like in the finest sense of the definition, is again stepping backwards in that disease process. So I feel like in my mind, when I have been claiming that there's reversal of this disease, I am thinking about a step backwards in that timeline of disease progression. And I feel like
the question is that clinically relevant? Is the degree of, is that clinically relevant, and what are the criteria for clinical relevance?
And I'm saying and I agree that it's yet to be proven that it's clinically relevant, but
okay.
In my opinion, all signs point to it will be proven in the future that it's clinically relevant. Prove me wrong.
We hope it will be. We hope it will be.
Wait, but I also want to step in and just say one thing. Even if any study met the criteria, I just want to clarify this just in case anyone's confused, met the criteria for 10% of a stenosis reversal, just so everyone's aware, that would actually still not change clinical management. Meaning, if your plaque goes from 40 to 30, you're still on your statin. Your plaque goes from 50 to 30, you're still on your statin. So I just want to make sure everyone knows that.
I agree with that.
About that,
it may change. Well, Danielle, it may change whether, like, if you reverse it enough, it may change whether someone will put a stent in, right? Like, eventually, if you go down to 30 from like 70, it'll change management for stenting.
It wouldn't. So the way. Okay, so stenting again. So we were discussing this before. This is an entire another bear. We could have an entire talk, but this is with regards to ischemia trial. Stents outside of ACS do not improve mortality outside of acute coronary syndrome. So stenting in general, with regards to just putting a stent into any lesion is morely symptomatic and palliative outside of acute coronary syndrome. So that's like not even, neither here nor there. So it's actually really not going to change the management at all. Like even a 20% change is not, it's wonderful. It would be, I will love if we do this study and we see a 30% plaque change, that would be awesome. But guess what? That patient still has to stay on their statin because they still have coronary artery disease.
I agree with that. Here's my question though. Is it not possible that there are other metrics that have yet to be established? For example, we know that stable plaques are less likely to cause acute events. would it be possible, maybe through new technology, to be measuring the prevalence and frequency of those unstable lesions and perhaps
so
seeing?
we look at the technology we use right now to
Yeah, right
visualize lesions. We use cardiac CT, so coronary CTA, where we can look at both hard and soft plaque. Okay, so that is even how I want to study it, because I think that is most accurate at this time. You would never do at this time a dietary intervention where you would evaluate it using cath at this standpoint ever, because there's just the risk of stroke or any risk with cath. It's not incredibly high, it's like 1 in 1,000, but it's still high enough that you wouldn't go in and do IVIS or OCT to evaluate a dietary intervention. So right now, the safest way you would evaluate it would be through cardiac CTA, because that is the way you can look at hard and soft plaque. Standard coronary angio looks at hard plaque, but if you do IVIS or OCT, you can see soft plaque because it's ultrasound. But the only non-invasive way to do it, which would be okay in a study, is cardiac CTA. It still requires dye, so it's still a risk for someone's kidneys, but it's more of a minimal risk than doing an actual cath procedure. You can see both hard and soft plaque. Unstable plaque, I mean, we don't really know a plaque is unstable until it ruptures. You know that someone has unstable symptoms concerning for something that needs to be stented. If they're having something called unstable angina, we have a definition for that, but that's symptomatic. That's not via visualization. Someone's having unstable anginal symptoms, that's considered acute coronary syndrome, and they need to go for a stent immediately.
Okay. It just, I was just toying with the idea that in theory, it seems like there are other metrics of cardiovascular disease that could perhaps measure a reversal or an improvement, but they just haven't been. And that was just a thought that, like, just because again it hasn't been clinically proven. Like, I have no problem admitting that we have yet to clinically prove it to those standards. But it seems like there are many ways.
Or the standard you, yeah. Or sorry, go ahead.
I think cardiac CTA, Mike, I agree. We are going to do this study. Like, I think cardiac CTA is the best for this, because it shows cardiac CTA is our best visualization of the coronary arteries right now, because it gives us soft and hard plaque. It's non-invasive. It's our best technology at this juncture.
What's your timeline for this potential study?
Well, we're Kevin Klatt's going to design it, but it's actually going to be all plant-based groups. We're going to look at different macronutrient compositions, but given everything with COVID, we're not applying for grants right now. But this is something in our purview of studies we want to look at.
Okay, so I'm gonna say right now that as somebody who's communicating health messages to the public, having multiple doctors say that a vegan diet reverses heart disease, having published literature saying, quote, a vegan diet is clinically shown to reverse cardiovascular heart disease, and seeing statements in Esselstyn's study, for example,
I know
that is reversed. Like, you could see how someone like me would be.
Yes, Mike, absolutely.
Mike,
Mike, listen. I agree. Completely agree with you, Mike. Like,
I completely
it's
agree.
very easy. And it's very unfortunate that this is in the literature, because it is so easy for people just like you, Mike, and just like a whole lot of people to
Mike,
be
you know what's so interesting? Like,
tell the story, Danielle. Tell the story about when you brought it to Journal Club.
Oh, well, so Mike, I totally agree with you. Like, I completely understand where you're coming from. I was a board certified internist when I started cardiology fellowship, and brought these papers to Journal Club, and had numerous interventional cardiologists say to me, this is not disease reversal, and literally brought up the exact same points Avi's brought up to me about how this is not clinical disease reversal based on all the literature and the cardiovascular data. And I was shocked, because I too didn't understand. And then I did 3 years of cardiology training, and now my understanding is much more different than it was 3 years ago. But I cannot blame you in the slightest at all, because I thought the exact same thing. I really did.
But is it also correct? Sorry, I just had a thought. Is it also correct that it hasn't been shown that a vegan diet doesn't reverse heart disease?
Oh yeah, of course.
So you can't make that
a lot
claim.
of things haven't been shown. Yeah, like it hasn't.
Okay.
Well, the claim is that it has not been shown that a vegan diet does reverse heart disease. That's a true claim.
Right.
With that clinical definition, yeah.
Yeah, or the definition, or even your standard by at least having to have some of the benefit come from an increase in minimal luminal diameter.
I,
Which wasn't
I still didn't. I didn't say that in
Okay,
particular.
you can go
I
back.
still,
You
I
can go
still
back.
believe. No. I still am trying to grasp my mind around this. And sorry, because we've only been talking for a bit. Still trying to grasp my mind around the the definition of reversal in terms of what reversal, on the truest sense, biochemically, in terms of what's going on with cells, is something being reversed or not? Is there a step backwards in the progression of a disease on any level, whether it is in terms of inflammation,
We're
in
looking at
terms of
clinically.
that's
looking at a
one
bar
definition of a reversal of a disease, though. Like you can, like you might.
Yeah, I mean, look, like yes, but there's there's always going to be some bar. Like again, if you statistically significantly reduce your LDL from 178 to 175, yeah, you can have a.
like, that was the,
I mean, it's like, but
this is the
no one's going
example
to be like,
I gave you.
yeah, I mean,
This
look,
is the exact. So Mike, I gotta say, so if you're in a calf, okay, and I'm doing a calf, this is the perfect example I gave Avi too. If I'm in a calf and my attending was in a calf when I was in a case like a month ago, and I called a lesion 50%, someone else with the exact same with different eyeballs could call it a 70% or 60%. Like that's how much variability there is, right? So saying that it drops by 3% is literally like me saying someone's LDL drops from like 117 to 114. So it's like, how clinically meaningful is that? Do you know what I mean? Like with regards to and I don't want to discredit how important, how much clinical meaningfulness there is of Ornish's trial, which is that the disease stops progressing. And I think that's what we should be focusing on that. I think it's so important that his research showed that,
yes,
hey,
absolutely.
lifestyle and diet interventions can stop disease progression. Stay on your medications, keep doing what you're doing, and your disease won't get worse. That is so wildly important. I think what the confusion comes in is when we say it reverses disease and people throw away all of their guideline directed medical and procedural therapies, and then that puts them in danger.
But you don't think it's okay to say that there's a reasonable chance that their disease will get better going up in terms of their disease experience?
There's experience. Well, yeah, we can say that. There's experience.
But for the average person, that is what their disease is, and that's the part where I feel like it gets to that's the problem with the gap between the doctor and the person, and the meaning of the word reverse.
Yeah, so I think that patients will understand. So like when I talk to my patients, when we talk about anginal symptoms, we say lots of different things can make it better. There's lots of medications. There's also lifestyle changes. There's many reasons to go on a plant-based diet, but it's symptoms. I totally get what you're saying, but symptom is different than actual reversal of the disease.
Yeah, because the reverse really just means. Yeah, sorry, Danielle's talking.
Yeah, we can say here's the, yeah. I just want to say, like, look, we want to be as accurate as we can to our patients, but we also want to tell them things that they can relate to and understand layman terms, and not take and to do damage. What I would say, and here's just what I put out: yes, your experience of your disease will be better. Your disease won't be reversed, but your symptoms will be reversed. Why don't we just call it something meaningful to the patient, but not something that is not true, not factually true, and something that could potentially mislead the patient? Why don't we just call it either an improvement? Why don't we just call it reversal of symptoms? Because that's what it is, or a decreased rate of events, or
which by the way,
all those things.
Which, by the way, the decreased rate of events
is more important than whether it's reversed,
and that's freaking important to me. It's so important to me. I literally every time
that's the key.
That is the key. Every time a patient sits in my office and they say, wait, I thought I could reverse my disease and I thought I could go off my statin, blah, blah. And I say, no, a plant-based diet is still important. It will actually reduce your chance of dying of X, Y, and Z in this many years. This is so powerful, but you still have to continue, all of your guideline-directed medical therapy. I don't know why we have to oversell it for it's such an amazing, dietary pattern that can help so many people, but reversing events is wildly important. And I think that is something we can advocate for without people getting confused that they no longer need, as I mentioned, these guideline directed therapies.
Yeah. Okay. I have two questions. Like, first of all, like just to quote the definition of reverse is just to move backwards. So there's clinically meaningful reversal or not clinically meaningful reversal. There's reversal on, there's just so many. Basically, I'm saying that there's so many interpretations of the term reversal, and that's why it's so easy to mess up. Second of all, is there any point, this is just out of curiosity, totally separate, is there any point where somebody's LDL would be too low that you would not give them a statin?
So okay, so for me personally, so if someone's LDL is too low, naturally too low, meaning like so if someone has coronary artery, it's not because their LDL was already too low, right? So when they come to see you, their LDL is obviously not too low. If someone's LDL gets really low because they're on so now with the latest research, our LDL targets are incredibly low. So if you have established coronary artery disease and you've had cardiac events, we will give them multiple medications, including PCSK9 inhibitors, to get their LDL below 50.
Below 50.
So
Okay. So I was just wondering if you have somebody who had heart disease, didn't, just on their own decided to go on a diet, plant-based diet, and then they came in with a LDL of, I believe mine is 38. If they did that, would you tell them to go on a statin, even so they have the disease?
Tell them to go on a statin. Well,
yeah.
I mean,
Yes.
So
yes, they will be on a statin.
Yeah, that's what I was just wondering.
Yeah,
Okay.
without doubt.
To lower their LDL, or what are the other benefits?
No.
Other benefits.
Statins are not just
They have
about
pleiotropic
LDL.
effects. There's pleiotropic effects of statins beyond just the LDL lowering effect. There may be some plaque stabilization effect as well for the statin. It's not just about LDL, but
I would just say that.
But also, I'm not also, just to be clear, I'm not ruling out any additional benefit of lowering the LDL even more from 30 to something even lower than that. I don't have any data specifically at that target range, but I'm not suggesting that there's no possibility that there's no further benefit of lowering it even further. But also there are benefits.
I was just wondering if there was a theoretical point where any risk, and you should tell people who are watching maybe what the risks would be briefly, but like could there be any time where someone's LDL is so low that it'd be more of a risk?
So for secondary prevention, the answer is no. For secondary prevention, if you have established CVD, you are going to be on a statin, and even if your LDL is 2, you're going to be on a statin.
Yep. Unless the only thing that will preclude someone to be on a statin is if they have
contraindication,
contraindication,
yeah,
which are far more rare than people believe.
Okay. So, I mean, I guess I'm satisfied. I mean, I feel like I feel like the message that I was putting out there is a message that is put out by many doctors, is in the literature, and is possible to be true in the future. But I have no problem admitting that the highest level of threshold has not been met, or what you would say the clinically necessary level of threshold has not been shown in the literature at this time. And but I do still say that there's reversal of someone's experience of the disease, which is just a really unfortunate situation, because if you go to somebody and they feel like they're making progress with their heart disease on statins and doing everything you tell them to do, and then they say, oh look, I've reversed my disease, and then you say no, like they're going to think I feel like they're going to be like, you're literally telling me to not agree with my senses, or that what I see and what I feel is wrong, because I'm feeling better, I'm doing better, and my disease as I know it is in some cases gone or close to gone. Even if it's not clinically gone, to say that just seems,
I mean, Mike,
like there's a gap here.
If a patient really was that, concerned, like they could get an easy CT. I mean, I would never recommend this, that someone that was really that curious ever do this. So I would never write a script for it, but they could get a CT and see that their disease is still there. I mean, that's why I would never recommend that, because why would you expose someone to radiation just to show them that their disease is still there? But at the same time, like, I think that in general, people underestimate how much patients actually do understand. My patients are so freaking smart that they understand when I say, like, oh, your disease is still underneath, but your symptoms are better, and that's important, and they get it. And I think that that's just an important discussion. Everything's a patient, and and no case is the same. We do have guidelines for a reason. They're guidelines, but every patient doctor interaction is the same. And I actually so does Rob Oswald. We spend a lot of our time explaining away this exact concept to our patients because of the misinformation out there.
So I still feel like it'd be very interesting to have a discussion with Esselston. Like, have you talked to Esselston and been like, hey, I don't think
I would love to talk to him.
I have not. No.
Because I think that would be.
I would love, and I would love to do it. I would love for him to give me the values? Like what is the? I would love for him to give me the percent stenosis, the reference diameter, and the minimal luminal diameter for all these patients, and the patients he said that reversal was experienced. And I'd love to see this unpublished data.
Because I feel like there's a conversation that needs to happen without me that's between Ornish, Esselstyn, at least Danielle, and Kim Williams.
Listen, I personally think that like neither myself or Avi are diminishing any of the work they've done. It's really, they've really made a huge impact in the plant-based community. What Avi and I are discussing, literally the definition, the clinical scientific definition of disease reversal. Like literally, I'm sure they're aware of the papers.
But I mean, correct me if I'm wrong, but Esselstyn still stands. I guess Esselstyn still stands by the title of his book, "Prevent and Reverse Heart Disease." I don't know if that's not true. If that's true or not, I assume it is.
I have no idea.
And then Ornish, I believe, says "Prevent and Reverse Heart Disease." I'm pretty sure I've heard him say that. I could be wrong. I don't want to speak for him. And then again, these presentations that are given by Kim Williams, as recently as 2018, was the one that I saw up, paint like I'm just gonna say a very different picture than what you're painting. So I feel like the larger plant-based doctor community like needs to have almost like a forum on this or something, because it's like clear, like if somebody can go to multiple peer-reviewed sources and read basically read that a vegan diet reverses heart disease or a almost entirely plant-based diet reverses heart disease, then and people are just going to keep on saying it. And so until like I said, like moving forward, at the very least, I'm going to be saying, like, I'll probably make a video follow-up saying that this is not clinical reversal of heart disease, and that my understanding of what reversal of heart disease is not what clinical reversal of heart disease is, even if it's someone's experience, and emphasize the fact that people shouldn't feel like they can reject conventional medication.
Like
I have no problem doing that.
Thank you so much.
But I also want there to be a greater conversation, because you're having people going around.
Well, I also think, I can't speak for everyone, but I can definitely speak with regards to guideline directed. Kim definitely is like so supportive of guideline directed medical therapy and procedural therapy. And he is like by the book, very, very, very like pro everything evidence-based. So I don't think there's confusion there. I think it's the confusion that comes down from the translation.
Literally the R word. It's how you interpret the R word. And so
yeah, I think exactly. And what's funny is that if coronary artery disease could truly be reversed by diet, don't you think that our cardiovascular guidelines would have that as the only intervention? You know what I mean? But we don't.
I would love to think that, but we have lobbyists.
No, that's
not
how the guidelines. That is not how the guidelines are. Guidelines are not made up by. The guidelines are made up by cardiologists.
Still influenced. I remember Kim talking about the formation of the guidelines and talking about the influences of. Am I wrong about that?
I'm not aware of any lobbyists that are in the guidelines. The guideline writing committee.
Or not lobbyists that are in, but people who are influenced by lobbyists. I'm not saying it's written by lobbyists. I'm saying that it's people who are influenced by lobbyists. That the people who were pushing, and people with low carb ideals that were pushing to get the recommendation to lower your cholesterol out of there, or having a cholesterol recommendation at all, and he was saying that he helped get it back in.
I'm not aware of that. I'm not aware of that.
So it seems, like I would love to.
Regardless, yeah, regardless, like if it does, hey, look, there's a bar that's been set. There is a goalpost. It's not going to be moved, all right? So that it is there, and if it's met, then we will advocate. We will not just advocate for it. We will say that it's been met, and we will say that okay, this is reversal. If it meets the criteria for the guidelines, we think it should be put in the guilines.
But I guess I have a final.
Yeah, sure.
I have a final question for Danielle. So do you think the people who had that, the before and after angiograms of the incredible results, do you not think that they reversed their stenosis? Do you just think that we don't know, or do you think it's possible?
I think that I have no clue, because let me tell you
something. Okay.
I'd want to know. First of all, I'd want to see. As I mentioned, there's so much variability with regards from even like within a case, the hemodynamics between one case. I have friends that are cath experts, that are interventional cardiologists, that are cath experts that do not believe that would alone show disease reversal, and these are people who do hundreds of caths a day that are very well known cath experts. But I think that no one can say based on opinion whether or not, like, I think that it's fantastic if it was. I wish it was, but I think that no one can say that based on opinion. You have to, that's why you have to follow to really decide if it was reversal. It would have to be done in a robust and rigorous way and meet a specific criteria. We just don't have that.
Okay, yeah. So it seems like, again, we just have to summarize that there is a gradient of quality of evidence required to say something does something.
Well, because Mike, let me ask you this. So the carnivore guy who posted his cardiac CTA showing that he had improvement of symptoms. So that is one case, right? So do we say that now a carnivore diet, or all of the people on the carnivore diet that reverse their diabetes? So do we say that that reverses diabetes, or that the carnivore diet reverses coronary artery disease based on a few cases? Do we say that?
I would say no, but then I would also say if the carnivore dieters came out with basically exactly the Esselstyn and the Ornish study, that there would be a stronger case to consider it, at least. But I mean,
but Esselstyn's is a case series, so it's just, that's the thing. You know what I mean? It's the same thing. It's case, like, so it's. I that's where I think it's hairy. So I think that the evidence has to be all in the same. We can't just go by, right, Avi? Like, it's just not going.
But I mean, you think?
so,
I mean, I don't know if you saw my video, but you think? I mean, do you think there's any statistical value to comparing what that
I think,
cohort of what that group of people had compared to the average?
So here's the thing. So, like, okay, so I don't want to quibble too much on this the statistics you did, because we're going to go into the weeds. Like, we can talk about whether the value, whether it's appropriate to talk about a one-tailed t-test or a two-tailed t-test and how you ask the question.
Right, exactly.
We can get into those things. We can talk about creating a virtual control group and what the issues with that are. But I don't see the point of quibbling about this, because I agree that the results of the Esselstyn study, in terms of events and in terms of symptoms, are amazing.
Yeah, and I'm saying if a carnivore study found the same thing, it would be compelling. Like if a carnivore diet study, but I don't think it would happen.
Yeah. Okay. We would call that amazing too, but we wouldn't say that that's reversal of CVD.
Right.
Yeah,
now, if we had the criteria for reversal of CVD, we would say it's reversal of CVD. Sure.
That's the point.
But yeah, exactly.
But there's a stronger case than just one dude randomly showing an angiogram. So that's what I'm saying, is there's a stronger case than just one dude's angiogram. There's
if someone put a gun to my head and say, like, which diet do you think would be the most likely to get there? Okay, the carnivore diet or the vegan diet, I would say the vegan diet would be probably more likely to get there than the carnivore diet, but I still maintain that neither diet has been shown to get there.
So here's the thing, is that most people aren't doctors and don't have medical responsibility, and so their quality of evidence is usually, unfortunately, lower.
I know.
And it is reasonable based off everything that you see in literature to say it looks like things are improving, and by improving, you can interchangeably colloquially use that with the term reverse. So we have an issue here.
Well, yeah, that's why we have strict standards for what we call reverse and what we clinically relevant reversal for atherosclerotic cardiovascular disease, and what we don't call. And that's why other interventions are put up to a given standard, and we want to be consistent unless we have a symmetry breaker that would justify an inconsistency.
So here's what
But with talking to our patients, it's very important to be able to tease out what is being meant, and we don't want to lie to our patients. We want to be honest with them. Your disease is not being reversed to a clinically relevant degree. Your symptoms can be reversed. You can live longer. More important than that.
More important.
You can live longer. Way more important than reversing your disease. You can live longer.
So let's think of a new term. Let's think of a new claim. Let's think of a new claim. A vegan diet. Okay, is it correct to say that a vegan diet has been shown to lower mortality risk?
Yes.
CVD mortality risk.
Absolutely.
Okay. Yes. Absolutely.
I mean, look at the study. Look at the study, healthful versus unhealthful plant-based diets, in JACC of 2017 June. Is like a great study that shows, like, they looked at like Nurses Health Study 2. They found that the more healthful plant-based diet you eat, the lower your overall mortality risk was, the lower your risk for cardiovascular mortality. I mean, I am constantly preaching the benefits of a healthful plant-based, plant-predominant diet for those very, very reasons, without saying that I'm going to reverse their coronary artery disease, because I don't know if I am.
So you would think it's okay to say that if somebody with advanced cardiovascular disease, coronary artery disease, goes on a vegan or plant-based diet, they will lower the risk of death from that disease.
Oh, I think so. Yeah.
On average, yeah. On average, yeah.
And Mike,
Okay.
Mike, listen, I so much so
All the
believe it
claim
that
I need to make.
I've even shared on social media. I mean, so on Twitter, cardiologists share cases all the time. I shared a case of a patient that demonstrated what's called cardiac reverse remodeling on echo on a plant-based diet. And I presented at PCRM conference this weekend too. And that is a case, a hypothesis generating case, and I present it that way, meaning it's a case that showed that their ejection fraction and their medial and septal velocities all improved on a plant-based diet, which is amazing. Do I have hope that maybe one day I'll find out in a randomized trial, cardiac reverse remodeling with a plant-based diet? Oh, yes, maybe there's the chance. But right now, the way I present it is, this is a case. This is a hypothesis generating case.
So using higher quality imaging, you found a case of somebody on a plant-based diet who showed reversal in an anecdotal way.
No.
Sorry,
So,
do you say?
So what's called so the terminology we use. So this isn't coronary artery. This is a totally different disease process. Systolic and diastolic heart failure, where the heart muscle.
But it's considered a heart disease.
Correct. But when I say I reversed their heart disease, we don't use that terminology. We have a specific, like Avi said, there's a specific definition for what we use when we call cardiac reverse remodeling. And like Avi said, this has been established for medication trials. So when we looked at Entresto, in Paradigm, in all these different trials, they have to create a criteria when they're looking at medications for what is what we call cardiac reverse remodeling in those trials. And based on those parameters, my patient had those improvements with medication, with guideline-directed therapy, but in addition to a plant-based diet. They've been stabilized on guideline-directed medical therapy for 2 years. They had kind of just sat there, plateaued. They went on a plant-based diet and they saw this improvement, but which is amazing. And I believe in plant-based nutrition, but I present this as this is a hypothesis-generating case, N of 1. It is just the means for me to develop a randomized controlled trial to really evaluate it. It could have just been by chance. This is just the best.
Okay, so it could have been by chance. Okay, but it just made me think of a kind of a funny question that you don't have to answer. Ignoring any public health messaging, gun to your head, if somebody asked you, do you believe that a vegan diet reverses heart disease?
Which heart disease?
Reverse.
You have to tell me. There are
any heart disease. Is there any heart disease that a vegan diet reverses?
You have to tell me. I have to tell you something. I know this sounds ridiculous, but when you say heart disease, for me personally, that's like, there are so many different kinds. Systolic and diastolic heart failure are different.
And look, that's the same problem with type 1 and type 2 diabetes, is just saying a vegan diet reverses heart disease, but diet reverses diabetes. But in terms of logic, if it is capable of reversing one segment of one population or one area within that category, then it is capable of reversing that category. So
what I'm talking about, do I think that in patients with heart failure there could be a potential for improvement with a plant-based diet? I have seen signals of that in a small case basis. I'm going to plan. It is hypothesis generating. I'm going to study it in a randomized controlled trial fashion, because from mechanisms, so based on mechanisms, there's plausible reasons why plant-based diet would improve it. But I would never, ever, 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 ever tell a patient, right now, I can improve and fix your heart failure with a plant-based diet. Does that make sense?
Okay, so I totally understand, but this is just a funny question. You don't have to answer it. Gun to your head, you get asked, is a vegan diet capable of reversing any heart disease? If you get the answer wrong in terms of what is biochemically true about the laws of nature, you die. Would you say yes or no?
I would have to say
in on average, or in some people.
Just is it possible?
No, I would die.
I mean, not is it possible? Is it what happens? Is it the truth of the human body?
The hill of evidence I will die on. Shoot me. I will die on the hill waiting for good evidence.
So we could be agnostic. No, you can be agnostic on that.
Got a little smile. I got Isaac to stop playing
That was funny.
So I'll answer it. Like, so for any heart disease, do I believe that there is any form of heart disease that a vegan diet can reverse? Maybe that in some population, maybe in some small segment, there will be some form of heart disease that may be reversed. If we're talking about averages, if the question is being asked on the average, is there any? I honestly don't know. if the question is being asked in terms of atherosclerotic cardiovascular disease, I also don't know. I lean towards maybe not, because the Ornish study is already out and we already have data not meeting the bar. So that's where I would stand right now. But I do acknowledge that it's possible that future data comes out and we are shown that it does meet the bar. And
also, I agree. And also, what's most important to me is that, like, more important than saying to my patients, this could cause disease reversal when I'm not sure there's a hypothesis generating case that shows X, Y, or Z, is the fact that it improves CV mortality. It improves your likelihood of not dying of cardiovascular disease. That is enough. That is enough to me to convince my patients to eat a more plant predominant diet.
Yeah, and that's honestly enough for me to say. It's just it's literally the notion that it's like when you're just making a claim about what a diet can do, you're making the claims that are in the literature that you see and that are there, and that's just one of them. In fact, it's probably more persuasive to say that you will die less.
Yes.
And that, you know, there's no reason to not say that. But then I will say that it's just in terms of like the semantics, and if you want to get into like logic propositions that Isaac is into, it's whether or not there's the question of whether or not it is ethical to say that it does based off clinical stuff, and whether or not it is a truth of the human body or not. And that's what I think is an interesting comparison. It hasn't been made yet. I do think that in the future, maybe when we have nano robots going through our bloodstream, that we'll be able to show many. I'm just techno fantasy joking, but there are probably many metrics that the highest level of cardiologist panel would say that is a reasonable metric of heart disease reversal. Like, I think this is what we have now is the 10%, but I'm still like appealing to crazy futures that we might have more ways of showing it or not.
So Mike, even if we saw 5%, I just want you to know, from a cardiovascular standpoint, as a cardiologist, that patient comes see me, even if their lesion. So I know I said this before, and I know that
they should still be on statins.
But there would be no change to whether their lesion was 45% or 50. We don't even. The fact is, we don't even talk about lesions in terms of 5 percentiles. You will not even see a cath report. Cath report, literally eyeball it, will do between, someone will say 40%, I'll say 60% or 50%. It also depends on the angle you're looking at, whether you're an LAO or REO funnel. There's different views. So the fact is that even if we did see a 10% difference, it's still the clinical management. You have to also understand, a lot of this is so nuanced. You have to think of also the patients, like with regards to what is clinically meaningful to the patient. They're still going to be on their medication. They're still going to continue their plant-based diet. It's not clinically meaningful to say to them that they've reversed their heart disease, whether it's 5% or 10%. Do you know what I mean?
I do. And I want to add that I believe that in the future, and like I'm starting to get too future speculative, but I believe that the treatment for a plant-based diet for heart disease is going to be refined. And there's going to be, like, for example, the nitrates thing. We can see whether or not the nitrates are working to the extent that we think they are. Add them, have actual regimens. There's maybe some things you can do to, if we find out that you can remove that plaque from those LDL particles from the wall, again, it has to do with your immune system, macrophages, and stuff like that, that there may be dietary ways to increase that as well. And that I feel like there's potential that there's going to be vegan diets, we already know this, that won't reverse heart disease. There's going to be some that pause it. And I do think in the future, and this is total speculation, that there will be highly effective vegan diets that are going to be more effective than the other ones at reversing heart disease. And I do, like, I'm still, call me a romantic, but I'm still holding on to the idea that it will be shown that there is plaque reversal.
Mike, I'm going to really blow your mind. You should really reduce it trial, because really every single cardiovascular patient should be taking 2 grams of EPA fish oil twice a day now, because it reduces cardiovascular risk so much.
I'd have to look at the study.
You got to look at it. So, like, I mean, the thing is that there's a lot of things that are changing. Like, one of the best trials that came out in 2019 was the Reduce It trial. And it's like super important that we, like, even as vegans, you have to keep your minds open, because we just have to be fair to our patients and give them the right information.
But I would also say what might be a benefit in a population that is primarily consuming like high inflammation inducing animal proteins, that might have a different effect than somebody that is like, I can't say for sure that if a vegan diet was given fish oil like that it would lower, or a vegan population.
No. So EPA, okay, I won't even go into it, but Reduce-It trial
Okay.
shows that high dose EPA improves cardiovascular risk reduction significantly in patients with known heart disease and diabetes.
Who are not on a vegan diet.
So it was not a diet study; it was a medication trial study. So therefore, I would not extrapolate that any dietary pattern. If my patient fits the criteria that they fit in the study, we would offer them that supplementation. So, I mean, that's just the way medicine works. Like, you can't just assume vegan diets are not bull. You can't just assume that based on, you know what I mean? Like,
Yeah,
you
but
still
people can still
follow-
take algae-based EPA
That's
and
not
DHA
that's
is the
not
same.
the same. That's not the same as high dose EPA. It's not the same.
Algae has EPA in it. I don't know
No,
why.
it's not the same as Vasepa. You have to read the reduced trial. 2 grams high dose EPA only. There's 0 DHA.
Yeah, but I'm saying you can make that out of algae.
I mean, sure, someone can make
Yeah,
a vegan
so it
version, but as a
doesn't have
physician,
to
we're
be.
not going to prescribe that.
Yeah.
We're going to be prescribing the one studied in a randomized
Even though
trial.
biochemically it's the exact same.
We don't know it's biochemically the exact same. You have to understand that's like malpractice. We have to follow guidelines, and you have to like follow things based on a trial data. We can't just go based on just, first of all, supplements are not even regulated by the FDA. There is no one that is regulating supplement industry whatsoever. Therefore, if there's a medication like a high dose EPA that's been studied in a randomized controlled trial that shows cardiovascular risk reduction in a certain population, you have to offer that to your patients who would benefit from it. I mean, this is like what I think that there's just this misunderstanding that physicians want their patients to live the longest, and being plenty of doctors who treat vegan patients have seen vegan patients that die of many other diseases, and it doesn't make you bulletproof. And the
Yeah,
best
I mean, I tell people all that time, like, even if you have a lower reduced chance of a disease, doesn't mean you're immune to it.
So the bottom line is that you really have to, the best bet is to follow guideline directed medical therapy in addition to the plant-based diet. I mean, it's all synergistic. It doesn't have to be one or the other. Like,
But I do just want to say for the record, I don't agree with what you said about the EPA, and we can just agree to disagree.
You can't literally not agree with me, because
I don't agree that something that's biochemically exactly the same, EPA,
trial that you haven't even
icosahexaenoic acid, is going to be different.
Literally, it's a trial.
But she was saying that we haven't, in order to prescribe it, you have to know that it's the exact same. So I'm sure she agrees that if you literally had a clone,
these fish literally get that from algae. That is how they form it. So
no, sure, you can.
Biochemically, it's different.
Yeah. We're not going to disagree. You can get biochemically, literally EPA from algae, and you could take away the DHA. You can get 2 grams of it. You can do that.
I think it might be worth considering if we're on topic. We seem to be going off.
We can get off. Icosahexaenoic acid is icosahexaenoic acid.
It hasn't been studied. That's the point.
Let me ask this. Okay, you guys disagree on this, but just for the sake of keeping it on point for the people watching the video, do we have any remaining disagreements about the conversation proposition, or would you guys like to maybe make sort of closing statements?
No, I think we did a good job, and I think we came to agreement, actually. I think so. We agree that for what is considered clinically relevant atherosclerotic disease reversal, as judged in the literature that has judged medications against this criteria, we don't have evidence yet to suggest that the vegan diet or plant-based diet accomplishes that. And even if we just consider that a requirement that we need to have both the minimal luminal diameter and the percent stenosis increasing, we also wouldn't meet that bar. I hope that we have that in the future. We don't have evidence that it's not going to do that. And I hope that in the future we will have evidence that it does. But more importantly, we have evidence that it does the important things. That it, on average, reduces your chance of dying, reduces your chance of getting another MI, etc.
Yeah, and that's what I would say. Like, from this point on, I have no problem just shifting to making that claim, because if, again, the problem lands in what is clinical, ethical to say reversal for people who are doctors or health professionals, and what is experiential reversal for people, and I have no problem granting that it's just safer to use the clinical definition, and that what people experience is not necessarily going to lead to the best outcome in terms of their like. It's unfortunate that you have to tell people that what they're sensing is not necessarily true, but I agree that it hasn't been shown yet, and so moving forward, I'm not going to be making this claim in the same way. I'm going to be claiming other things about what a vegan diet does for heart disease and mortality. And furthermore, again, that I am of the belief that in the future, based off the inklings of evidence that we've seen so far, based off the mechanisms of what happens within an artery, and that we can see lowering on IVUS, lowering volumes of those fibrous fatty things, that it might be possible that we might see more reversal
We
than
hope
we
so.
know. And
We hope
so
so.
it's open. It's an open book. We all agree that the outcome should be the same. That people should still be
Yes.
listening to their cardiologists and still be taking the medications, because if they're going to lower your chance of death, they're going to lower your chance of death. And like, how ego aside, taking a pill or not. I mean, unless again you're saying if someone has an adverse reaction, that's different. But
Yeah, but there's a
appreciate you saying that.
contraindication. That's one thing.
Yeah, of course.
contraindication.
And we appreciate you
Anything
saying
from
that,
you,
because I think
Danielle?
that-
Closing remarks?
Oh yeah, I just want to say I so appreciate you saying that, Mike, because I think it's so important that people in the plant-based community don't feel ashamed to be on medications. There's nothing wrong with it. I find that there's too many patients that feel there's shame in the plant-based community, that it's almost like they're doing something wrong that they still have to take medications. And there's nothing wrong with it. Everyone wants people to live their longest and healthiest life with a combination of guideline-directed therapy as well as obviously a plant predominant or plant-based diet. And I think it's really important that we destigmatize that, because someone needs to be on medications for the rest of their life. That's okay. That doesn't mean that they're, doing anything wrong with their diet. Their diet can be perfect. And I just hope, and the one thing I just want to touch on really quick, just to clear up with symptom reversal, I understand your confusion, but the best example I can give is that, and Avi, I'm sure, has seen this in medicine all the time, is that symptom reversal doesn't necessarily, like he mentioned before, mean the disease is getting better, although that doesn't minimize the fact that symptom reversal is important. With regards to even heart failure is the best example. Comes in really overloaded, give them Lasix, they get rid of the volume, they feel a ton better, but it actually doesn't mean that their disease has gotten better. So symptom improvement is super important, but that's why that is different than disease reversal. And I think we all agree that plant-based diets are super healthy and help to prevent cardiovascular disease, like further risk reduction for cardiovascular disease in general. So we really appreciate you even having this conversation with us.
Yeah, absolutely. And I look forward to like hearing people being in part of this discourse, like Kim Williams and stuff like that, so we can like round out the community messaging or whatever.
Guys,
Sure,
I think we've had a great conversation. I
Okay.
really appreciate everyone participating. Obviously, if you guys want to follow up, you all, we have a group conversation. So, yeah,
Absolutely.
have a good day, guys.
I'm just gonna read some super chats. You guys can stay or you guys can leave. You don't feel any obligation to stay.
Well, I don't have a choice, but yeah, I'm just kidding. I will gladly stay for the super chats.
So Capone says, thanks so much for these great debates to help us seek the truth. This was very insightful. What's your opinion on Michael Greger and Garth Davis? I know they are very different in their approach. Funny you ask. We have a video coming out shortly enough on the topic of Michael Greger. And with Garth Davis, I don't know a whole lot about Garth Davis. I know I wanted to have a discussion with him about IGF-1, but that hasn't materialized yet. Thank you for the donation. Next, we have Josh T. Says, can you comment on what kinds of oil and how much of them are healthy, safe to consume according to the literature? I don't trust Dr. Greger anymore. I don't think, I'm not saying, look, I don't think people should be guzzling oil. I don't think people should be start drinking a whole. Now, that being said, I don't think we should be demonizing oil either. I think that there is some evidence to suggest that that certain amounts of oil may not be harmful, like olive oil. I don't think that canola oil is that harmful, and I don't think it is harmful in appropriate doses. We're not talking about pouring a whole bunch of it on your spaghetti, and then so it's just an oil spaghetti soup. But yeah, no, I am not part of the. I don't consider myself one of the you have to have a no oil vegan diet. The next Cold Poison says, Thanks, Mike, for being honest. I'm happy when we clear up large claims made in our movement because it's a shame for outsiders to mix the bigger picture. We agree as well. Thanks for the donation, code Poison. Redheaded Princess says, 2 hours in, I'm always happy to watch the replay. Always happy to see Isaac and Avi together. Hearts from a redhead cockroach.
Classic.
Thank you for the donation, Redhead.
That's funny.
All right.
Okay, with that.
Thanks for coming, guys.
Yeah.
Alrighty. Yeah, it was great. Okay, I'm gonna close the stream now.